Becker, our Chief Medical Officer, will take you through the safety of the vaccine, with a focus on the characterization of this very rare but serious event of thrombosis with thrombocytopenia, then conclude with our framework for how we think of harnessing the benefits of this vaccine for the US and the globe while responsibly managing its risks. Just this past week, there have been nearly 40,000 hospitalizations and over 4,700 deaths in the United States, and around 10x or more of that number globally. The pandemic continues to rage in the face of the vaccine rollout. Importantly, many people face obstacles to accessing a vaccine, and we know that the J&J vaccine has been particularly important to people who live in rural or remote areas, for example, and who lack the type of healthcare infrastructure required for other options. I want to review a particularly important feature of the J&J COVID-19 vaccine measured in our phase 3 trial. We demonstrated strong protection offered after severe disease after day 28 of a single shot, with 100% protection against hospitalization and 100% protection against death. And what's most notable is that this pattern of protection was true also in regions such as South Africa and Brazil, where the 484K containing mutations are dominant. In South Africa, for example, we saw equal efficacy to that measured globally, including 85% protection against severe COVID, 100% protection against hospitalizations, and 100% protection against death. These results are supported from an ongoing study in South Africa, where we have now over 280,000 healthcare workers vaccinated, and these healthcare workers have significant and sometimes repeated exposure to B1351, the South African variant. Of note, the participants are primarily women and primarily under the age of 50. As with our phase 3 study, there have been no hospitalizations or deaths after day 28, and only 3 breakthroughs after day 28 of the 280,000 vaccinated people. The B1351 variant contains 3 mutations and 1 deletion on the tip of the spike protein, rendering the neutralizing antibodies induced by all the vaccines about 80 to 90% less effective than they are against neutralizing the original strain of the virus. This goes for our vaccine too. We believe that the excellent efficacy we nevertheless maintain against the variants is in part due to the T-cell immunity that recognizes so many epitopes of the spike protein that's very challenging for the virus to circumvent the vaccine. And our vaccine in particular has excellent T-cell immunity and has so by design. It's quite important to monitor these variants, as a particularly infectious and resistant one can take over very quickly, especially now that we're effectively applying selective pressure through natural infection and vaccination. So B1351, as you see from the yellow area in this graph, went from non-existent to becoming the dominant variant in South Africa in a matter of 8 weeks. Now it's nearly the only circulating variant in that country. And disturbingly, B1351 has been found circulating in 36 of 50 US states and territories and across Europe. Several variants containing also the key mutation of position 484 have also been reported in the United States, starting in New York City. Beyond this important high-level protection of the vaccine against variants, the J&J vaccine has other features that allow it to play an essential role in the effort to contain COVID-19, both in the United States and globally. Our vaccine is the only authorized vaccine that uses a single-dose regimen. The benefits of this dosing cannot be overstated, considering the urgent mass vaccination campaign we're in the midst of. Whether it's in rural communities that lack access to healthcare, or transient populations like farming communities that may not be able to in the same location for a second dose, the one-shot benefit is critical. The vaccine also has a relatively quick onset, with vaccine efficacy against severe disease seen as of day 7 in the pivotal trial. Available immunogenicity data from the phase 1 study up to day 115 are in line with the historical platform data and thus very promising with regards to durability of protection, also in the elderly. And last, but certainly not least, the vaccine is compatible with existing vaccine distribution channels and can be stored for 3 months at normal refrigerator temperatures. What this means for achieving vaccine goals should not be underestimated. We have the ability to reach locations in the United States that other vaccines may not. These features of the vaccine allow vaccination of people that might otherwise not be able to or choose not to get a shot. That is, there may remain part of an unvaccinated segment of the population. All in all, the J&J vaccine plays a critical and complementary role to other vaccines. To be explicit, one concern is that absent or a restricted J&J vaccine does not just delay the full vaccination of the US population, but potentially leaves unvaccinated a proportion of the US population. And if the unvaccinated population is large enough, we put at risk reaching herd immunity in the US. And the global context is also critical here. As global mobility resumes, there's no question that US residents remain vulnerable so long as large swaths of the globe remain unvaccinated and variants therefore continue to emerge. And for many parts of the globe, the single dose and easy transport and storage features of the vaccine are absolutely critical. A restriction in use here could have a negative impact on the success of achieving global herd immunity. The pandemic in the US will not truly end until the world has indeed achieved herd immunity. So we believe this perspective is critical for today's discussion. Let me now hand over to Joanne Waldstreicher.
Thank you for the opportunity to meet today. Safety is our highest priority, and we've been laser focused on identifying and understanding the very rare occurrence of CVST and other thromboses together with thrombocytopenia, as well as working with FDA and other regulators on appropriate labeling to ensure awareness and guidance on diagnosis and treatment. There's been extensive outreach and communication of this event over the past week, which has stimulated a number of additional reports on this important and serious event. As we saw in Dr. Shimabukuro's presentation, there are 15 post-authorization cases of thrombosis with thrombocytopenia, all in women, most under 50 years old. Most of these cases were CVST, and some also had thromboses at other sites. I want to say that I use the word cases, but these cases are not just numbers to any of us, and we take them very seriously. These are people, and we need to understand and characterize their risks. In exploring the context, we will show the rates in relation to other background rates. This is meant to be a general comparison of orders of magnitude of risk, not a direct comparison. So let me now place this into context. When we look at the cases reported post-authorization, there have been 15 cases reported among nearly 8 million people vaccinated. That gives a reporting proportion of 1.9 cases per million people. To compare this to the background rate, we did an initial focus of CVST with thrombocytopenia. Our analysis of 5 large observational US healthcare databases that included over 60 million people estimated the background rate of thrombosis CVST with thrombocytopenia to be approximately 0.1 cases per million. The evaluation of other thromboses with thrombocytopenia is ongoing, but many of those cases are confounded by other diagnoses such as cancer and other illnesses. In reviewing the interim Brighton criteria and speaking with experts, as well as evaluating the data thus far that we see in healthy people, we recognize that this is likely extremely rare. Here we show the observed cases of thrombosis with thrombocytopenia per million people on the bottom in comparison to other vaccine-related adverse events on the top of the line. By no means do we mean to equate all these events with the seriousness of thrombosis with thrombocytopenia, but we felt it was important to note the frequency of these events, such as intussusception for rotavirus vaccine, immune thrombocytopenia associated with MMR, Guillain-Barré for H1N1 vaccine, and anaphylaxis in the pre-COVID era from vaccines, all of which range from approximately 1 to 70 cases per million people. The fact sheet agreed upon with FDA describes that the clinical course of thrombosis with thrombocytopenia after our vaccine shares features with autoimmune heparin-induced thrombocytopenia. This is estimated to occur between 1,000 and 50,000 cases per million heparin users, which is a different patient population than the vaccinated population. Heparin-induced thrombocytopenia, as you heard earlier today, can be associated with life-threatening thrombosis, and it also requires proper diagnosis and, importantly, consideration of alternatives to heparin, as with thrombosis and with thrombocytopenia. Let me now turn our focus to women under age 50. Amongst the 1.9 million women in this group, there were 13 cases, which is a reporting proportion of 7 cases per million women. To contextualize the risk for women under age 50 further, we look to consideration of the labeling and known labeled association of oral contraceptives and thromboembolic events, including stroke, myocardial infarction, and CVST. Again, I want to emphasize that by no means are we equating these types of events with one another. However, I use this as an example of where there are options for healthy younger women, each product with its own benefit risk and product profile, among a variety of other options, each with unique characteristics, such as long-acting injections, transdermals, different hormonal generations, and even non-hormonal methods, and each with risks that are addressed with warnings in product labeling and clear information in the patient information leaflet. Ultimately, the risk of thrombosis with thrombocytopenia should be put into context with the benefits of vaccination. This slide is a benefit risk assessment in adults 18 years of age and older. Based on the efficacy data from the randomized pivotal trial and the reporting rate from spontaneous reporting, we could expect that if 1 million people in the United States were vaccinated with the J&J single-shot vaccine, there would be over 2,000 fewer deaths and 6,000 fewer COVID-related hospitalizations on the benefit side, and at the same time, approximately 2 additional cases of thrombosis with thrombocytopenia. When we look at the benefit risk assessment in women under 50 years of age, if 1 million women in the US were vaccinated, there would be 2,600 fewer COVID-related hospitalizations and 116 fewer deaths on the benefit side, and approximately 7 more thromboses with thrombocytopenia cases. Janssen fully supports the public health recommendations from regulatory agencies and medical societies to create general public awareness, as well as to provide specific guidance for medical professionals regarding this very rare but serious event following vaccination. We're committed to active follow-up to identify and investigate all cases and have an ongoing effort to fully understand the pathophysiology. Our observational study protocols are designed, and we are examining the feasibility of multiple databases, not only from the US, but also from the rest of the world. We fully support the guidance from the CDC and professional societies that outline awareness, education, diagnosis, and treatment. In addition, Janssen is implementing several initiatives, including healthcare professional and consumer support, professional education, posting fact sheets on our websites, and a 24-hour global hotline. We absolutely agree with the FDA on the implementation of a warning within our label and patient and physician fact sheets describing this very rare event, including how it can be identified early and diagnosed and treated. To that end, here is the language from our label that we have agreed upon with the FDA regarding thrombosis with thrombocytopenia. In addition to the description of the event, healthcare professionals are alerted in the fact sheet to the signs and symptoms of thrombosis with thrombocytopenia in individuals who received the COVID vaccine from Janssen. It also states that symptoms began approximately 1 to 2 weeks following vaccination, and that most people were females aged 18 through 49, and that some cases have been fatal. Healthcare professionals are also directed to the published American Society of Hematology considerations relevant to the diagnosis and treatment. In addition, the patient fact sheet contains a clear warning and instructions. J&J strongly supports this enhanced labeling. In conclusion, the benefits of Janssen's effective, single-dose, and easy-to-use COVID vaccine continue to outweigh its risks. We continue to face a deadly pandemic, and existing and emerging variants are making containment even more challenging globally. Every day matters in our campaign to control the virus, and we need all options available as the effects of COVID infection can be both serious and long-term. The Janssen vaccine offers many benefits in this context, including early efficacy and including demonstrated efficacy in South Africa with the B.1.351 variant predominating, and simplicity in terms of its single-dose administration, shipping, storage, and handling. As such, the vaccine provides access to people who are underserved, as well as certain populations that typically face barriers to healthcare services. As Dr. Mammon mentioned, our concern is that with the restriction, it's not just about delaying vaccination, but potentially leaving unvaccinated a portion of the United States. And if the unvaccinated population is large enough, we put at risk reaching herd immunity. It's also important to recognize that decisions in the U.S. have an impact globally, and with delayed vaccination and potential increased vaccine hesitancy, variants that emerge globally ultimately impact the U.S., especially as global mobility resumes. A restriction in use here could have a negative impact on the success of achieving global herd immunity, both here in the U.S. and globally. The pandemic will not be over until a large segment of the global population is vaccinated. We recognize that there is a very rare but important and serious risk, and J&J fully supports increased awareness, education, and enhanced labeling. With these efforts, we aim for earlier recognition and making this event more identifiable, diagnosable, treatable, and with improved chances for successful outcomes. In summary, we believe the J&J COVID vaccine is central to the effort to end the pandemic. Thank you, and we look forward to answering your questions now, as well as any questions you may have during the discussion.
Thank you very much for those presentations. We'll now open this up to questions with the voting members' priority initially. I'm not seeing any hands. Liaisons, do you have any questions? Again, I'm not seeing any hands. All right, the speakers will be on the call, and if there are any questions, oh, Dr. Shaw, I'm sorry. Go ahead, please.
Thank you, Dr. Romero. Just a brief question for our colleagues. Given their experience with other adenovirus vectors, other adenovirus vaccine vectors, have we seen cases of similar thrombosis with thrombocytopenia?
This is Matai Mammon. I'd like to ask my colleague, Johan van Hoek, to comment on your question, Dr. Shaw.
Thank you. The techniques of your day. With regard to your question, why indeed there are similarities between the other vaccine, which is reported in Europe, the AstraZeneca vaccine, and ours. It is important also to note that there are quite some important differences between both vaccines. That relates both to the vector that is used. The one is a chimp adenovector. The other is a human adenovector, and we do know that they belong to different species, and also it has been demonstrated that there are differences in host cell receptor and also interactions with other host factors, which could lead to potentially differences in innate and adaptive immune responses. There's also differences in the transgene that has been used. We do have a transgene that is stabilized with a knockout of the S protein, fusion in the region, deletion in the fusion region, and also we have it stabilized with 2 mutations, which is not the case for the other transgenes. So at this stage, while indeed there are similarities and certainly the clinical picture is very similar, at present there seem to be some differences also in the reported frequency, although we realize it's still early days. And so we think it is somewhat premature today to conclude that we can automatically extrapolate all the findings from AstraZeneca to the Janssen vaccine. But we do recognize that the clinical picture is very similar. So there might be a difference in frequency or eventually in mechanism.
And sir, I apologize for the lack of specificity in my question. That's my fault. I was thinking of other COVID vaccines that utilize an adenovirus vector, such as the Sputnik vaccine, and then other non-COVID vaccines that may also utilize an adenovirus vector.
We do have, we cannot comment on the Sputnik vaccine. We don't know exactly what has been reported for that one. With regard to other adeno-based vaccines, there are not that many licenses for the moment. We do have one vaccine, an Ebola vaccine, that also uses the same adenovector. We have looked in detail to the database that we have for that vaccine. Of course, we don't have the millions that have been vaccinated. We today have more than 200,000 people vaccinated with the Ebola vaccine, and we have not observed any of these phenomenon in that particular clinical trial setting. We also have other vectors in other vaccines in clinical development using the same vector, specifically an HIV vaccine, for which we have several thousand women also vaccinated today. Of course, the data and the numbers are limited, but also important to note that we have not seen any sign of a similar phenomenon in those trials.
Thank you. Dr. Alt.
I was actually going to ask the very same question that Dr. Shaw asked, so I'll put my hand up.
Thank you all. All right, we'll ask Drs. Mammon and Waldenstreicher to still be on the call, and if there are any other questions for them, we'll ask them to come forward. Thank you again for that presentation and answering those questions. So now we'll move on to the next presentation, the VAST assessment by Dr. Grace Lee, who is the ACIP VAST's co-chair and vice chair of the ACIP. Dr. Lee, please.
Thank you very much, Dr. Romero. You can move to the next slide. Thank you. I wanted to take a moment to place the events of the last week in context, particularly given the multiple work groups involved. The ACIP Vaccine Safety Technical Subgroup, or VAST, reviews vaccine safety data on a weekly basis. Risk assessment is a dynamic process, and we are constantly reviewing new data from all available vaccine safety surveillance systems in the US and have been since the first vaccine was administered. The ACIP COVID vaccines work group focuses on benefit risk assessment, placing the information about benefits and risks in the context of the ongoing pandemic in the US. And benefit risk assessment is also a dynamic process that is continually updated as new information emerges. Finally, the ACIP committee today deliberates on all available information in order to make recommendations for use. As we're doing today, we will revisit recommendations as new information emerges. Next slide. The VAST work group specifically reviews, evaluates, and interprets post-authorization COVID-19 vaccine safety data, serves as a central hub for technical expertise from federal agencies participating in vaccine safety surveillance, advises on analyses, interpretation, and data presentation, and provides updates to the ACIP COVID vaccines work group and the ACIP on COVID-19 vaccine safety. But more importantly, the reason we have such a focus on vaccine safety is to ensure that the public has confidence in vaccines and in the US vaccination program. Next slide. To date, VAST has had 17 independent meetings to review and discuss post-authorization vaccine safety data. In addition, VAST members have joined additional meetings of the COVID-19 vaccines work group for specific review and updates of safety data presented on those calls. Next slide. So I'll focus in on VAST's role in risk assessment and the thought process of the VAST work group. On April 12th, 6 cases of CVST with thrombocytopenia were identified as a rare but serious potential adverse event following the Janssen vaccine. We noted that risk factors for CVST with thrombocytopenia were not well understood, and the work group felt strongly that timely and transparent communication with healthcare providers and the public would be crucial to maintain confidence in the vaccination program. Next slide. Within 24 hours, CDC and FDA colleagues released a communication along with a safety pause to ensure that there was immediate awareness by clinicians, public health colleagues, and the public of this potential adverse event. Next slide. On April 14th, ACIP convened an open meeting to discuss CVST with thrombocytopenia to ensure transparency and public awareness. At that time, we reviewed reported cases of CVST with thrombocytopenia after COVID-19 vaccines, and we discussed the need for additional information to support evidence-based decision-making, including age and gender-specific risk estimates and an evaluation of the benefit-risk balance of using the Janssen vaccine in specific subgroups. Next slide. At the VAST meeting on April 19th, we reviewed the new Brighton collaboration definition of thrombosis with thrombocytopenia syndrome, or TTS, which you heard about today from Dr. Shimabukuro. That is a broader definition in use now. But having the standardized definition is critical to facilitate investigations across surveillance systems in the US and globally. So I just want to take a moment to recognize and thank the Brighton collaboration team for their quick work on this definition. VAST noted that the Health Alert Network, the HAN, was extremely useful for supporting enhanced case finding in the US. And at that meeting, VAST requested additional information on the age and gender-specific rates of TTS following the Janssen vaccine for further risk assessment. Data from the VSG and the VA rapid cycle analyses were reviewed, and no safety signals were identified for CVST, other thromboembolic disease, or thrombocytopenia following the Janssen vaccine, with over 200,000 doses administered at that time across the 2 systems. We also received an update from the WHO Global Advisory Committee on Vaccine Safety on TTS cases following the AstraZeneca vaccine. This included a better contextual understanding of the country-specific approaches to use of the AstraZeneca vaccine that are driven by those country-specific benefit risk assessments. Next slide. So at yesterday's joint VAST and COVID vaccines workgroup meeting, additional safety data were presented, and we discussed the risk for TTS following the Janssen vaccine was 7 per million doses in females less than 50 years of age, with the highest rate noted in women 30 to 39 years of age. In contrast, the risk for TTS was less than 1 per million in females 50 and older and males of any age. Other potential risk factors included obesity, oral contraceptive use, hypothyroidism, and hypertension, but we really don't have enough information to make a determination about whether they are true risk factors or associations. There were 3 deaths, 7 remained hospitalized, and 5 have been discharged home. And the group also discussed benefit risk assessment and the evidence to recommendations framework during that meeting. Next slide. So in summary, where we are today, we recognize that TTS is a rare potential complication potentially associated with the Janssen vaccine, and that the risks should be balanced against the benefits of preventing death, hospitalization, and thromboembolic disease associated with COVID-19 infection. VAST notes that the risk of TTS appears highest in females less than 50 years of age, and other risk factors for TTS are not yet well established. Risk mitigation strategies may include the following. Number 1, minimizing exposure in high-risk populations. Number 2, increasing awareness and ensuring timely diagnosis and management of TTS. And number 3, educating patients and the public about the benefits and risks of available vaccines. FAST will continue to monitor TTS, thromboembolic disease, and thrombocytopenia in all available vaccine safety surveillance systems. And we will continue to update the ACIP COVID-19 vaccines work group, the ACIP Secretariat, and the full ACIP committee on a regular basis. Next slide. I just want to take a moment to thank our VAST members for their continued public service and dedication to ensuring vaccine confidence in the U.S. And I also wanted to thank our intrepid CDC co-leads, Lori Markowitz and Melinda Wharton, and our ex officio and liaison representatives and administrative support team. I also wanted to personally thank all of our vaccine safety colleagues in the Immunization Safety Office and the vaccine safety investigators in VAERS, VSG, CISA, VSAFE, VA, FDA, CMS, and DoD for their round-the-clock work on vaccine safety since that first dose was administered in the US on December 14th. Thank you.
Thank you. We'll now go on to presentation of thrombosis and thrombocytopenic syndrome, TTS, after COVID vaccines. Applying the evidence to recommendation framework. Presenting will be Dr. Sarah Oliver, who is the CDC lead for the COVID-19 work group. And before she begins, I want to thank her and her group for all the work they've done on this issue and on all the other issues that have come before us beforehand. So thank you very much, and please go forward.
Thank you, Dr. Romero. It has absolutely been a group effort over this last bit. So good afternoon. Next slide. Next slide. So for previous votes for the use of COVID-19 vaccines, we've used the evidence to recommendation framework. It's a structure used to to describe information considered in moving from the evidence to the ACIP vaccine recommendations. It provides transparency around the impact of additional factors on deliberations when considering a recommendation. Next slide. As a reminder, this is the policy question that was originally voted on for the Janssen vaccine. Should vaccination with the Janssen COVID-19 vaccine, 1 dose, be recommended for persons 18 years of age and older under an EUA? Next slide. This is the traditional evidence to recommendation framework used for previous recommendations. While it's helpful, it doesn't necessarily fit the type of questions facing ACIP today. Next slide. So we've adapted the evidence to recommendation framework to a risk-benefit assessment for the Janssen vaccine recommendations. We'll be using many of the same domains to lay out the information that we have available. First, for the public health problem, we'll be describing recent COVID epi, as this is what is most relevant to policy decisions made today. Then we'll provide a high-level review of other information that may inform the discussion, including thrombosis seen after COVID, an overview of CVST, the epidemiology of HIT, or heparin-induced thrombocytopenia, and what is currently known from the AstraZeneca vaccine. Then under benefits and harms, we'll discuss the benefits of the Janssen vaccine, harms associated with the Janssen vaccine, and our data on the benefit-risk assessment of COVID vaccines. Next slide. Then we'll discuss values and acceptability, including the intent to receive a 1-dose vaccine and how that has evolved over time. For feasibility, we have rapid recent surveys of jurisdictions over their use of the Janssen vaccine and the possible impact of Janssen vaccine policy options. And finally, we will highlight the possible impact the Janssen policy options may have on disproportionately affected populations. There are no data for resource use available to inform these discussions. And before we go in detail, now that we've highlighted what we're about to lay out, I just personally want to take a moment to thank the team of people who have done about 6 months worth of work in this last week to pull it together. Our data team, which conducted the risk-benefit assessment, and the modeling team, which helped provide the models to inform this assessment. So next slide. So first, describing the public health problem. Next slide. Again, this is what we'll be reviewing. Next slide. So this slide shows the trend in number of COVID-19 cases in the US. Through April 17th, we've had around 31 million cases. We had the rapid decline in cases since the winter, but with a stable to slight increase in recent weeks. Next slide. This is the daily death curve with over 560,000 deaths throughout this pandemic. Next slide. So this is a map of the US where each state is shaded by the most recent 7-day case rate, where the darker colors represent a higher incidence. Next slide. This slide highlights the epi curve from 2 states, one with a high incidence currently and rising, the other with a lower stable incidence. This is more to highlight that in a country this large, the epi of COVID is not the same everywhere. The pandemic is dynamic, and states can experience highs and lows at different times. Next slide. We also can't talk about recent epi without acknowledging the SARS-CoV-2 variants in the US. This slide shows circulating proportions and overall, and then the proportion of cases from variants of concern or variants of interest has increased. And you can see here in recent weeks, nearly half of the cases are the B.1.1.7 variant. Next slide. We also have to acknowledge what is happening in the US with COVID is only a portion of the picture as well. This map shows a recent global incidence rates with a darker blue representing a higher rate in the last 7 days. Next slide. So again, the recent COVID-19 epidemiology will be the most informative for policy decisions made now and moving forward. So we're going to focus in on the epi since March 1st. Next slide. This slide shows the incidence by age and by sex. The highest incidence for new cases recently is actually females 18 to 29 years of age. Among adults less than 50 years of age, females have a slightly higher incidence compared to males, and this is reversed in the older populations. Next slide. This slide shows recent hospitalizations by age and by sex. Older adults have much higher rates of hospitalizations, with older males as the highest rate. Next slide. And finally, this slide shows mortality rates by age and sex, where older males have the highest rates and all younger adults have a lower mortality rate. Next slide. This slide shows the recent incidence by race and ethnicity. Disparities in incidence by race and ethnicity are noted. Next slide. This slide shows mortality by race and ethnicity. And again, you can see disparities by race and ethnicity noted. Next slide. So to summarize our COVID epi data since March 1st, for incidence, the cumulative rate is just over 700 per 100,000 population, where younger females have the highest incidence of new infections. For hospitalization, the cumulative rate since March 1st is 20 per 100,000. Most hospitalizations still occur in persons 65 and older, but it's worth noting that the proportion of hospitalizations occurring in this population is declining. For mortality, the cumulative rate since March 1st is 3 per 100,000. Again, where most COVID deaths are occurring in older populations, but the proportion occurring in this population is declining as well. Next slide. So next, we'll briefly cover the epi of several other relevant conditions. We've heard throughout today about CVST, as well as splanchnic vein thrombosis, or SVT. The overall incidence of CVST is around 14 to 28 per million. There is a wide range, and many of the differences in incidence that you may have heard from last week and across presentations this week is accounted for by this next fact, that the incidence has been steadily increasing in recent years. It's thought that this could be related to better detection by wider use of more advanced neuroimaging. CVST rates are higher in young women, and in traditional CVST, risk factors are identified in most cases. The mortality rate is 5 to 10%. Splanchnic vein thrombosis incidence is higher, with around 80 to 180 per million, with a higher incidence among men. And it's worth noting that the incidence with thrombocytopenia of either of these conditions is much lower than the incidence without thrombocytopenia. Recent estimates for CVST with thrombocytopenia are around 0.7 to 1.6 per million. But again, estimates for this condition are impacted by time and overall increases in CVST. Next slide. So heparin-induced thrombocytopenia, or HIT, occurs in 0.5 to 1% of patients exposed to heparin. This translates to somewhere around 20 to 45 per million in the US population. Of patients with HIT, thrombosis occurs in 20 to 64%. As we've heard described earlier today, it's an immune-mediated event with antibodies directed against platelet factor 4. There are risk factors for transitioning from HIT to HIT with thrombosis, which includes genetic factors, a lower platelet count, higher titers of PF4 antibodies, and prior surgery. Next slide. So CVST can occur after COVID-19, although it is very rare and in less than 0.1% of hospitalized COVID patients. Translating this to overall numbers, it could be estimated to be around 5 to 6 cases of CVST per million SARS-CoV-2 infections. CVST plus thrombocytopenia in COVID patients appears to be extremely rare. Any clots with COVID appear to be pathologically different than TTS after COVID vaccines. There was a preprint study that looked at PF4 antibodies in a history of patients with confirmed COVID. Overall, 90% of those were negative for PF4 antibodies, and all were negative on functional assays. This included patients who had thromboembolic events with their COVID infection. Next slide. There was one study described or mentioned earlier today that looked at electronic health records to look at CVST and portal vein thrombosis in COVID patients. They showed a low incidence of CVST in any 2-week period, but 2 weeks after COVID estimated an incidence at 39 per million hospitalized COVID patients. Cases of CVST were rarely seen after receipt of mRNA vaccines in this administrative data. However, there are limitations to interpretations of this administrative data. They were unable to assess the incidence of CVST after either advector vaccine, either the Janssen or the AstraZeneca vaccine, and did not provide rates of CVST plus thrombocytopenia. So it limits the direct ability to compare rates of CVST plus thrombocytopenia seen after COVID vaccines in the US or Europe. Next slide. So then briefly walking through what we know about thrombosis with thrombocytopenia after the AstraZeneca vaccine in Europe. Around 160 cases of CVST, 53 cases of splanchnic vein thrombosis were reported through early April in Europe. The EU estimates this to be around 10 cases per million, but acknowledges a higher incidence in younger adults. Their cases, again, were mostly in women less than 60, and within 2 weeks of receiving the first AstraZeneca vaccine dose. The EMA concluded that the benefit risk was still favorable to use the vaccine, and a causal association was likely. No specific risk factors to date, but they acknowledged that the epi may be related to vaccine delivery across Europe. They also added a warning for unusual blood clots and low platelets to the label as a side effect. Next slide. The UK recently provided updated numbers through mid-April with 168 reports of blood clots with low platelets, 72 cases of CVST. The male-female split seen is slightly more even with a broader age range, was discussed in our first presentation today. They note a rate of 7.9 per million doses. The UK has also decided that the benefits continue to outweigh the risk, but JCVI, or the UK's version of ACIP, recommended that persons between 18 to 29 years of age at low risk of infection be offered other vaccines. Next slide. Earlier this week, the EMA also met to review 8 of the cases of TTS after the Janssen vaccine reported in the US. They felt that the cases were very similar to cases occurring after the AstraZeneca vaccine. Similar to AstraZeneca, they concluded that a warning should be added to the product label. However, they also emphasized that it was a rare event, the benefits outweighed the risk, and emphasized the importance of healthcare provider awareness. Next slide. So this slide just pulls together what we've presented over the past several slides into a single slide, with the COVID outcomes in blue on the left, HIT, CVST, and CVST with thrombocytopenia rates across the top, and then the rates of TTS after AstraZeneca vaccine are shown in the box. Next slide. So now moving to benefits and harms. Next slide. So again, we'll highlight the benefits of the vaccine, harms, and our overall risk-benefit summary. Next slide. The phase 3 trial of the Janssen vaccine demonstrated efficacy against symptomatic, lab-confirmed cases of COVID with an overall estimate of 66.3%. Efficacy against hospitalization was 93%, and higher efficacy against severe outcomes was noted. Efficacy against severe disease remained high in various world regions, suggesting protection against severe disease with variant strains. Next slide. This was a slide shown from our former ETR presentation with a plot showing similar efficacy across age, sex, race and ethnicity categories, and among those with and without underlying medical conditions, at least 14 days after vaccination. Next slide. There are also benefits beyond efficacy. This vaccine is able to be shipped and stored at refrigerator temperatures and is a single-dose series, which may make it easier to reach some disproportionately affected groups. Next slide. Regarding possible harms of the Janssen vaccine, Dr. Shimabukuro described this in detail, so I won't go through it all again, but highlighting the findings here. Nearly 8 million vaccines administered, with 15 confirmed cases of TTS, with a rate of 7 per million in women 18 to 49 years of age, almost 1 per million in women 50 years of age and older, and none in men noted in post-authorization surveillance, although we do acknowledge that 1 case occurred in a man in the clinical trial. Next slide. So now I'm going to walk through our formal risk-benefit analysis. We're going to show this from 2 different perspectives. As ACIP thinks through these policy decisions, you'll need to think through the population-level risk-benefit and an individual-level risk-benefit. Therefore, we'll be presenting results from 2 different analyses that look at each of these perspectives. First, for the population level, we'll quantify COVID infections, hospitalizations, and deaths averted under different assumptions about resuming Janssen COVID vaccines over a 6-month period. Then we'll use that data to quantify population-level, age-specific benefits and harms of resuming vaccination with Janssen COVID vaccine. Then for the individual-level risk-benefit analysis, this was a more direct patient-level evaluation looking at a 1-month period to quantify the direct age and sex-specific benefits and harms per million Janssen vaccine doses. Next slide. So first, for the population level, objective of the modeling was to quantify COVID-19 infections, hospitalizations, and deaths under different assumptions about resumption of the Janssen vaccination. In all scenarios, we assume continued use of mRNA vaccines. There were 5 scenarios evaluated: that the Janssen vaccine was not resumed, that it was resumed starting tomorrow for all adults 18 years of age and older. This was then at 50% of a pre-pause administration rate or 100% of a pre-pause administration rate. Then that the Janssen vaccine resumed tomorrow in adults 50 years of age and over only, again at a 50% pre-pause administration rate or 100% pre-pause administration rate. Next slide. Our modeling team developed a compartmental model used to simulate incident infections, hospitalizations, and deaths over the course of the epidemic in the US. This is an updated version of the model, which has previously been shared with ACIP and is stratified by age, essential worker status, and underlying conditions. The model was recalibrated with incidence data through spring of 2021 to be consistent with the ensemble from round 4 of the multiple model scenario hub. We modeled age group specific vaccination coverage through April 2021 that also accounted for age group specific vaccine hesitancy when calibrating anticipated coverage. We modeled 2 types of vaccines, mRNA and Janssen vaccines, with VE estimates informed by the clinical trials and assumed to develop 14 days after administration. We assumed no loss to follow-up with mRNA second doses, no delays in administration, and we also assumed no waning immunity over the future 6-month time horizon. Next slide. So this slide looks at time to complete vaccination for all intending adults. During and after the vaccine pause, administration of mRNA vaccines continues at the same rate as the week before the pause began until demand is fully met. If use of the J&J vaccine, the Janssen vaccine, is not resumed for any ages, then it takes approximately 14 days longer to meet all vaccine demand. However, in practice, the pace of administration may slow as those experiencing barriers to access and/or greater hesitancy may comprise a greater share of those unvaccinated. Next slide. So this graph illustrates how the results of varying the resumption strategy might be influenced by the population vaccinated. Hold on, I may have skipped. Yes, sorry. This model was calibrated to be consistent with the ensemble from round 4 of the multiple model scenario hub. We modeled both low transmission scenarios, shown in blue, with a higher and longer sustained compliance with non-pharmaceutical interventions, and a moderate transmission scenario, shown in black, with non-pharmaceutical interventions easing more quickly over time. Next slide. So then this graph illustrates the results of varying the resumption strategy may be influenced by the population vaccinated and administration rate under this moderate transmission scenario. So the blue bars show the percent reductions in infections, hospitalizations, and deaths, assuming resuming vaccination in persons 18 years of age and older. And the green bars show a much lower percent reduction in those outcomes when limiting Janssen vaccine to person 50 years of age and older. Additionally, the lighter and darker bars show the difference in model results depending on administration rate, with 100% administration rate resulting in greater reduction than the 50% administration rate. Next slide. So now this graph on the right shows the model results under a low transmission scenario with a slightly lower percent reduction. And the outputs from the model on this slide were used in the population risk benefit calculations that follow. Next slide. So again, we use the outputs of that model just shown to quantify the age-specific risks and benefits of resuming vaccination with Janssen COVID-19 vaccines, including the risks of TTS and the benefits, including prevention of COVID-19 related hospitalizations, deaths, and ICU admissions. Next slide. From the model, we use the numbers of hospitalizations and deaths due to COVID-19, the number of persons estimated to receive the Janssen vaccine after the pause based on a variety of conditions, including, again, low and moderate transmission, 50 and 100% of the vaccination pause, and then the resuming vaccination in over 18 and over 50%, and over 50 years compared with no resumption. The estimates are modeled for a 6-month time horizon. And additionally, data from the CDC pandemic planning scenarios on age-specific proportions of hospitalized cases admitted to the ICU, CDC counts of the observed TTS by age, and numbers already vaccinated with the Janssen COVID-19 vaccine data before the pause were used. Next slide. So here we show the scenario where vaccination is resumed in persons 18 and older using the conditions of moderate transmission and vaccination with the Janssen vaccine at 50% administration rate before the pause. These are the number of additional benefits for the entire population and harms compared to not resuming vaccination with the Janssen COVID-19 vaccine. In the scenario of resuming vaccination for all persons 18 years of age and older, we expect 2 TTS cases among 50 to 64-year-olds and 24 cases among 18 to 49 years, and a many greater times reduction in death and ICU admissions. Overall, if vaccination with Janssen COVID-19 vaccine were resumed in all adults, the model predicts that 26 cases of TTS will occur among the 9.8 million persons vaccinated, and that about 2,200 deaths and 1,400 ICU admissions would be prevented. Next slide. So now on the right, the scenario of resuming vaccination only for persons aged 50 and over. There are 2 cases of TTS predicted, again, only among 50 to 64-year-olds. The number of deaths and ICU admissions prevented are much smaller than the scenario of resuming vaccination for all adults, but the benefits still outweigh the smaller risks. The model predicts 2 TTS cases in 3.6 million vaccinations, which would prevent around 250 deaths and 800 ICU admissions. Next slide. So summarizing the risks and the benefits for all the scenarios included in the model, considered suggesting upper and lower bounds of population effects for resuming Janssen COVID-19 vaccines. When resuming vaccination among all persons at least 18 years, we expect 26 to 45 TTS cases, depending on vaccine uptake, and expect between 800 and 2,500 fewer admissions and between 600 and 1,400 fewer deaths compared to not resuming vaccination with the Janssen vaccine. When resuming vaccination among only persons 50 years of age and older, we anticipate 2 to 3 TTS cases and between 300 and 1,000 fewer ICU admissions and between 40 and 250 fewer deaths. With this approach to assessing the risks and the benefits, we note that the benefits of vaccination apply to the whole population over a 6-month period and result from both direct and indirect effects, whereas the risks only pertain to the vaccinated persons. Next slide. So now we're going to move to the second level that we talked about considering. We just showed the population level benefits and risks, and next we're going to move to the individual level benefits and risks. The population model did not inform the direct individual benefits and harms for vaccination of that individual and was not able to look at sex-specific effects. So we used a simpler direct estimation approach to explore risks and benefits for females and males in different age groups per million Janssen vaccine doses. The calculations were based on recent age-specific incidents of hospitalization for COVID, VE against hospitalization observed in the trials, total Janssen vaccines to date, the number of persons already vaccinated, and are calculated assuming a 30-day period of not being vaccinated. Next slide. For females aged 18 to 49, we estimate that for every million doses of Janssen COVID-19 vaccine administered, we would expect 13 cases of TTS and would expect to prevent 12 deaths, 127 ICU admissions, and 657 hospitalizations due to COVID in 1 month. Next slide. On the right, we see the estimation for persons 50 years, for females 50 years of age and older. There are only 2 cases of TTS per million vaccination doses, but we would expect to prevent nearly 600 deaths and over 1,000 ICU admissions and nearly 5,000 hospitalizations due to COVID. Next slide. In males aged 18 to 49, We incorporated the one TTS case that was observed in the phase 3 trial in this estimate. Per 1 million vaccinations, we might expect a small number of TTS cases and would expect to prevent 11 deaths, over 100 ICU admissions, and 600 hospitalizations due to COVID. Next slide. So then in males 50 years of age and older, we expect 0 cases of TTS and could avert around 700 deaths, 1,500 ICU admissions, and 5,000 hospitalizations due to COVID. Next slide. So the population and individual approaches to the risk-benefit analysis offer complementary information on the risks and benefits of resuming vaccination and in which age groups. The population approach takes into account both direct and indirect or herd effects of vaccination. It incorporates the availability of different vaccines, simulates incidence, hospitalizations, and deaths over the course of the pandemic, and makes estimates on all outcomes over a 6-month time horizon. This approach shows a large population benefit of vaccination relative to a rare occurrence of TTS. Next, the direct individual level approach estimates the benefits and risk to vaccinated individuals and only considers getting a Janssen vaccine versus not getting any vaccine over a short 1-month time horizon. The analysis shows a positive balance of benefits and risk for all ages and sex groups. However, the stratified results suggest that the relative balance and risks for individuals varies by age and sex. Next slide. So now moving to values and acceptability. Next slide. We'll present intent to receive a 1-dose COVID vaccine, an intent to receive a Janssen vaccine over time, and the effect on overall confidence. Next slide. So prior to authorization of a Janssen vaccine, we conducted a survey that asked if there was a 2-dose or a 1-dose COVID vaccine available, which would you choose? And this survey was conducted in February of 2021, prior to the pause. Overall results were presented back in March 1st, when ACIP voted on the use of the Janssen vaccine. However, we now examined this data by age, sex, race and ethnicity, and income. Overall, most responders said that they would be willing to take either vaccine offered to them. However, 6% of individuals said that they exclusively preferred a 1-dose vaccine. There were no differences in the proportion that preferred a 1-dose vaccine by age, sex, or income, but there were significantly more Hispanic than white respondents that exclusively preferred a 1-dose vaccine. Next slide. So there have been several other surveys conducted over the past 1 to 2 weeks. At the time of this last survey, only 37% of Janssen respondents called the Janssen COVID vaccine safe. That was announced, this was after the pause was announced. This represents a drop of about 15% over 2 to 3 days. Another survey found that Americans are less likely to prefer a Janssen vaccine, with 13% decline in preference for the vaccine, which ranged from 9 to 25% across age and race categories. Next slide. This slide shows a figure from one of the surveys demonstrating a willingness to get each vaccine over time. You can see in recent weeks, the willingness to receive a Janssen vaccine has declined substantially. Next slide. So then trying to look at overall vaccine confidence. One survey found that the drop in vaccine confidence did not appear to extend to the Pfizer or Moderna vaccines, where most felt that they were safe. A recent poll did not suggest reduction in the intent to be vaccinated, and instead found that people were 40% more likely to receive a vaccine compared to 1 month ago. One survey did find a proportion of those who remain unvaccinated may be less inclined to receive a COVID vaccine after the pause, regardless of the brand. Next slide. So moving to feasibility. Next slide. We were able to conduct a rapid survey of each U.S. jurisdiction for the use of the Janssen vaccine and the impact of the Janssen vaccine pause and potential recommendations. The figure on the left shows where jurisdictions had been using the Janssen vaccine. You can see that many jurisdictions were using this vaccine in specific populations, including persons experiencing homelessness, homebound populations, and incarcerated individuals. The figure on the right shows settings where jurisdictions were using the Janssen vaccine, which included mobile vaccination clinics, emergency departments, and student health centers. Next slide. We then asked jurisdictions for the impact if the Janssen vaccine were only recommended for specific populations. Summaries of responses are presented here. Jurisdictions felt that they may need to reconfigure some of their vaccination sites, update scheduling tools, and may have difficulty serving disproportionately affected populations. Many stated that providers may need to carry multiple vaccines. Health departments also expressed concerns about communicating changes to the public, and again highlighted the difficulty serving disproportionately affected populations, for populations who are at risk for not returning for a second dose, race and ethnic minorities through mobile vaccination, and in rural or hard-to-reach areas. Next slide. So this slide shows jurisdictional thoughts for an impact if the Janssen vaccine was no longer recommended. Jurisdictions were primarily concerned around second dose management if only 2-dose vaccines were available, and equity concerns. Janssen vaccines provided flexibility for jurisdictions to avoid second dose management, run mobile clinics, and fully vaccinate people who may need to complete a series quickly. Jurisdictions noted some individuals expressed a preference for a Janssen vaccine, and increasing challenges to reach homebound, transient, or rural populations. Next slide. So finally for equity, next slide. This is from the same jurisdictional survey, and most was highlighted before, but we're highlighting here, again raising concerns from the jurisdictions around equity. Jurisdictions continued to mention 4 populations at risk of disproportionate impact: persons experiencing homelessness, homebound populations, incarcerated individuals, and migrant or seasonal populations. It was felt that if the Janssen vaccine were no longer available, these populations may be disproportionately impacted. I won't go through and read the quotes, but they're here and highlight the concerns and disparities from various jurisdictions. Next slide. So now we'll talk about the policy options for the use of the Janssen COVID-19 vaccine. Next slide. This slide was showed at the ACIP meeting last week. There's a spectrum of options for the Janssen vaccine. First, ACIP could decide that the risks outweigh the benefits and vote to not recommend use of the Janssen vaccine due to these safety concerns. ACIP could decide that the benefits outweigh the risks overall and recommend use of the vaccine in all adults 18 years of age and older. There's also an option in the middle of the spectrum, recommending use of the Janssen vaccine in some populations. Next slide. So these were the 4 policy options discussed by the work group. First, recommend against use for all persons. Next, reaffirm recommendations for all ages and sex in the content of the FDA warning statement within the EUA that was mentioned earlier. Next, recommend vaccination for only adults 50 years of age and older. And finally, reaffirm recommendation for use, but women less than age 50 should be aware of the increased risk of TTS and may choose another COVID-19 vaccine, such as the mRNA vaccines. Next slide. I'll walk through some highlighted pros and cons for each of the 4 options that were discussed. First, to recommend against use in all persons. A pro would be that there would be no further development of cases of TTS after the Janssen vaccine. However, the cons would be that it would remove choice from individuals. It could lead to excess COVID-19 cases and deaths, and could disproportionately impact at-risk populations who have barriers to access or difficulty returning for a second dose. Next, the population to reaffirm for all ages and sex in the setting of the FDA warning. This would allow for flexibility and choice and allow for use of the vaccine in harder to reach populations. However, it would place the burden on the individual to understand the risk and on health departments or providers to convey this risk. It may lead to more cases of TTS. And it's worth noting that at-risk populations for COVID-19 are likely at risk for barriers to identification and prompt treatment for TTS if it should occur after the vaccine. Next slide. So next, to recommend vaccination for adults 50 years of age and older. This would remove a vaccine from the most at-risk population and thus sharply reduce expected TTS cases. In addition, a single age cutoff is easy to communicate. However, it would likely be difficult to implement, where vaccination sites could need to stock 2 different vaccines. It would remove an option in a population that's actually at lower risk, men less than 50 years of age, and could disproportionately impact at-risk populations. And finally, the 4th policy option, to reaffirm recommendations for use, but recommends that women less than 50 should be aware of the increased risk and may choose another COVID vaccine. This would allow for flexibility and choice and allow for use in the vaccine in hard-to-reach populations while still acknowledging the risk in young women. However, it could still be difficult to implement, again with sites possibly needing to stock 2 vaccines, and could be difficult to communicate. Next slide. So next I'll highlight quickly a summary of the workgroup discussion that occurred yesterday. There was concern by many that a detailed personal level discussion of the risk-benefit balance is difficult in many of our current vaccination settings, such as mass vaccination clinics. Recommendations that may require vaccination sites to require 2 types of vaccines is difficult to implement. Access to vaccines for hard-to-reach populations remains important, and that the risk-benefit balance may change as the pandemic evolves and the risk of COVID-19 changes. Next slide. So again, the workgroup discussed benefits and concerns with all policy options. There was no single policy option as a clear choice from the workgroup. However, many on the workgroup appreciated the flexibility with broader recommendations for use, but acknowledgement of the elevated risk in women less than 50 years of age as the 4th option that was previously shown. Next slide. As a reminder, this is the previous vote. The Janssen COVID-19 vaccine is recommended for persons 18 years of age and older in the US population under the FDA's emergency use authorization. So our question proposed to ACIP, given the review of the benefits and risks presented here, what recommendation does ACIP feel is appropriate for the use of the Janssen COVID-19 vaccine? Next slide. And I'll leave these up for discussion. Turn it back over to you, Dr. Romero.
As always, thank you for a wonderful, detailed, and lucid presentation. So this is now open for discussion. We'll begin with the voting members. Let me pull up my screen here. Are there any comments or questions? Dr. Bernstein.
Spectacular presentation. Thank you, Sarah. The question that I have is, oh, I'm sorry, I don't know I'm echoing.
We hear you well.
Okay, good. I was interested with the 4th option that says reaffirm recommendations for use. Women aged less than 50 years should be aware of the increased risk of TTS and may choose another COVID-19 vaccine, that is mRNA vaccines. I was interested to know some more detail on how that women aged less than 50 years would become aware of the increased risk of TTS. I asked at last week's meeting, adding a warning to the EUA that's already 6 or 8 pages long. I was concerned that such a warning would be overlooked or missed. And I was wondering what's being proposed to convey that important information.
Dr. Bernstein, this is Amanda. I can respond to that. Yes, we awaiting ACIP's recommendation. We will have prepared, if this is the direction ACIP goes in, we will have tools both for providers as well as a public education to inform women and providers about not only the risk, but what signs and symptoms to be aware of if you do choose to get COVID vaccine. And we'll do this through, high level infographics and other ways to convey this information in a much simpler way than will be communicated in the very comprehensive and complete patient FAQ form in the EUA.
Thank you.
Dr. Sanchez.
Thank you. Sarah, that was wonderful as always, and thank you. I understand the complexity a lot. I understand the having a permissive acceptance of the vaccine would be like a shared decision-making that we have been doing for other vaccines. I actually was very interested and was going to ask even the Johnson & Johnson officer, Dr. Altschlager, if they had information on the acceptance of the vaccine after all of these cases have been reported in the media and in the literature. And I see that it's down to 19%, so thank you for that information. My concern is that that currently I think very few places, at least that I'm aware of, have options for different vaccines. And if we only have the Janssen vaccine available, there will be a lot of people who may, if that 19% is true, they will choose not to take that one. So I think that we're going to end up having to have other vaccines, and other vaccines are available, as we all know. I also understand the rationale for comparing this vaccine to an unvaccinated population and the risk benefits with that. But the fact is that we do have other vaccines that, at least at this time, don't have this. We have not seen the TTS. So I remain concerned. I understand the shared decision-making and having that option for individuals, but I also find that it would be very interesting to see how many, after we actually inform them of this potential risk, if that number 19% might even go down further. And so I think it's a really difficult decision, but I also think that that if it is approved and we recommend against, in the use of any of these, I think that we really will need to have choice available at different jurisdictions. Thank you.
Thank you, Dr. Sanchez. Dr. Long.
Yes, first, so that I understand the very fantastic modeling. First, on the population level, it was quite compelling. Is that all based on your assumption that it would take 14 days longer to immunize the population than if you had this vaccine available for all? I just missed that part of it. And similarly, as Dr. Sanchez asked, the decision to compare individual direct benefits of the vaccine versus none, is that because you wanted us to understand what would happen if an individual refused other vaccines?
So I'll take the second question first. I want to highlight the population level model included mRNA vaccines, our current and projected supply over the next 6 months. So the population level really kind of was the situation as it is in the US. The individual patient level model really tried to take into account that the thought that there might be a time period weighing the risks and the benefits if that individual is unable to get access to another vaccine in a short period of time. So I'll say that the population level looked over time with the mRNA vaccines, that individual level, that's the reason it was a short time horizon, because we assumed that the delay would be low. Then back to your first question, that 2 week, it was kind of a 2 to 4 week, that was actually an output from the first model, assuming kind of the current situation right now in the US. So the time delay was an output of the model, not an input to the model. And Rachel is on, our fantastic modeler. Did I say it correctly, and do you have anything else to add?
That's a great response, Sarah.
Thanks.
This is Amanda.
Can I ask one more question along this line?
You have the floor.
Thank you. Why did you just not at all think about giving this just to males who are younger? That was about 3 double negatives, but I bet you get it.
I think I understand. When we had to choose the scenarios for the modelers to put in, that was based on the initial discussions from the work group last week, that an age-based recommendation is something that jurisdictions felt, could potentially be communicated and discussed, but having a sex-based recommendation would be both incredibly difficult to communicate and really difficult to implement. So when kind of push came to shove, that is why we chose to not to go with the age-based as opposed to the gender-based.
Could you just enlighten me a little bit about how someone declaring whether they're male or female would be so much more difficult to implement than declaring their age?
Dr. Long, this is Amanda. I think that some of the challenges, for example, if a family came, it's not around somebody declaring their gender, and as much as it is where different groups of people access vaccines and the different types of places that would have to potentially carry multiple types. I think that the work group recognized the same challenges with the age restriction as well as with the gender restriction. And I think that, there was also, over the course of the week, there was, there have been reports of male cases that are under, that some of which may have been ruled out or whatnot, but I think that the risk in males is still not completely, while appears to be very low, there is still likely some risk. I want to say that I've been getting some reports that some of the listeners have been having trouble hearing some of the ACIP members, so please just speak closely to your mic. Thanks, sorry.
Next, Ms. Bata.
Thank you, and thank you, Dr. Oliver, for this incredible presentation. One of the things that I've been hearing since the pause has started has come from several of our BIPOC communities, our Black, Indigenous, and people of color communities, in that they perceive that the vaccine has been targeted to, the Janssen vaccine has been targeted to them, and we're already concerned about the number, the efficacy number, but they're also concerned that this could be a subpar vaccine in terms of safety. And so I think that's a piece that needs to be thoughtfully considered. And it may become irrelevant, but I didn't see the race. I know that we had race breakdown last week, but do we have any additional knowledge about the impact on race, ethnicity?
This is Sarah. I am not aware, and again can defer to Rachel, of any kind of specific model outputs from risk and benefit that we were able to obtain from kind of the population level at a race and ethnicity level. What I will say is it felt like that many of those concerns came out in the jurisdictional surveys as well, which I think communicate many of the concerns that you raised. Rachel, I'll go to you though quickly. Do you know of any race and ethnicity output that you guys were able to get from the model?
No, the models look at persons within an age group, and they do not distinguish between different races and ethnicities, what their contact patterns would look like, nor their risk of severe outcomes. So unfortunately, that's not an output of the model shown here.
Okay, thank you. And then what is the feasibility of vaccinators being able to have two vaccine products? And I'm thinking in terms of the upcoming availability of vaccines. In the past, we really haven't had much of a choice of what vaccine we're going to get. And can we accommodate that flexibility so that if we would do something like a reaffirmation of the recommendations, but notification to women under 50, could we have an option for them based on supply?
Ms. Bata, I can start, and then Dr. Romero can also join, but the distribution at the national level would continue to be the same, and it would be local decisions about where vaccines went to different sites. Dr. Romero?
So if you'll permit me, I'll throw my Secretary of Health hat on for the state of Arkansas. So this would be an implementation issue that would be dealt with at a local, statewide level, and we would have to adjust to that, and understanding that that is the case, we would probably have to flex to do so. Again, this is speaking only for my state, and if the representative from ASTHO would like to come and say anything, that would be appreciated also. But I think we can, honestly, accommodate a recommendation of that nature. So, Dr. Shah, if you wish, you feel free to make a comment.
Thank you, Dr. Romero. Again, this is Neerav Shah, speaking on behalf of ASTHO. It is feasible to accommodate multiple vaccines as well as prescribe different recommendations for individuals. But as Dr. Oliver noted in her exceedingly fantastic presentation, it does introduce logistics challenges of two natures. One is that it requires an adjudication of some decision. And in a time when we're trying to vaccinate as many folks as possible in any given period of hours, it might slow things down. Even a couple of percentage points may have an impact. The second, though, and what I've heard from pharmacists across states, is that carrying multiple vaccines does introduce the possibility, small though it may be, but real, about the possibility of errors of different sorts happening.
And then this is one again, I just have one additional comment, and this is just in the context that we are looking at a very rare risk and the high benefit and the need to make all vaccine available to all of us, and that we need that flexibility. And so I would tend to look for the decision with the fourth consideration.
Thank you for those comments. Dr. Paling.
Yes, thank you. First, Dr. Oliver, thank you. This presentation, and I want to thank you and all of your colleagues for this great presentation and the huge volume of work that you have presented. I particularly am focused on recognizing that we are in the midst of an ongoing pandemic, and that in the population level, the benefits are far greater than the cases of TTS. And I also very much appreciate the many hard-to-risk populations, as well as the very important point that Ms. Bato shared about making sure we communicate and don't make people feel like the vaccine is targeted to any one group. The second point is I wanted to say thank you for the individual assessment, because that provides a very important component as I'm thinking about it. And when you look at the individual, for all groups you presented, the benefits clearly outweigh the risk, though there are differences in age groups, and particularly for women less than 50 years of age. And for all of those reasons, I am leaning towards the fourth choice as well. Thank you.
Is someone speaking?
We don't hear anyone.
Don't hear anyone either.
Dr. Romero, you might be on mute.
Dr. Fry, can you hear us?
Yes, thank you.
Sorry, go ahead.
Dr. Fry, go ahead. Sorry, it may have been my microphone that was not working.
Oh, thank you. I think it was. But anyway, I was going to ask two questions. Well, first of all, Dr. Oliver, thank you and your team for just a really great, very terrific presentation. I was going to ask the question that Ms. Bata has posed very nicely and was responded to again very nicely, and that was one that had to do with resource poor areas and race. So I'm just going to skip to my second question, which I don't expect an answer to. I asked this question at our last meeting, so I'll just pose it and you can reflect on it later. But we have spent a lot of time on this particular question of what to do about these very rare events with CVST and thrombocytopenia. And I'm just curious, again, at what point, what would trigger us revisiting this question? In other words, I know that everyone is following these cases very closely. They're being reviewed on a weekly basis and in some cases a daily basis. But at what point would we come back to this? And I'm only posing this because I'm trying to think forward about how many times we might change a recommendation. Do we revisit it when we see 2 times the amount of cases that we're seeing now? Do we revisit it when we cross the baseline number of cases? And again, I don't expect an answer. I just want to put that out there for food for thought. Thank you.
Dr. Fry, this is Dr. Oliver. I'm happy to. So I will say we plan on revisiting all of the recommendations. So everything was voted on under the EUA. So as we transition to BLA, we can reassess a larger amount of data in the setting of the pandemic then. So there is a time to kind of reassess at that point. With regards to a specific safety signal or safety issue, I would say we would do the exact same thing we did this time, which is very closely monitor. We've got the safety group meeting weekly, the work group that meets weekly. And so if there's anything that raises concern, that would go through those channels through VAST, through the work group, and come to ACIP as soon as possible. Hopefully we don't have to do this again, but I think we have shown with this really exactly how the system would work and how we would, if there's anything concerning, how we would kind of immediately bring it to ACIP.
Thank you.
This is Jose again. So let me make a comment for the general public and for anybody who's not aware of this. I'm sure that all of the members on the ACIP and the liaisons understand. But it is not uncommon for the ACIP to modify their recommendations. And that's been done before. And most salient in this is the use of the IPV, OPV recommendations that were undertaken for pediatrics, where they were completely modified over time as the risk-benefit ratio for the use of a vaccine like IPV became higher and higher. So, again, this is not something that we have not done normally. So, did you have any other comments?
No, thank you.
All right, very good. Dr. Talbot. Dr. Cotton?
Thanks for the excellent data and modeling, which has been really helpful to review. In addition to all the factors you considered, we should also consider the impact on immunocompromised patients. It's estimated that approximately 2 to 4% of the US population is immunocompromised. And what we're seeing across numerous trials is a markedly decreased level of protection from the COVID-19 vaccines. Clinically, we're also seeing many patients infected well after 2 doses of the mRNA vaccine, many of whom have severe disease. And we are very concerned that with ongoing viral replication, the risk of producing novel variants is significant. They may be more pathogenic, they may be more transmissible, or they may even have resistance to vaccine-produced immunity, which could then have an impact on the entire community and our ability to defeat this pandemic. So in my field, there's a lot of interest in providing either booster doses or alternative vaccine administration. I've heard that this is being done in other countries such as France and Israel, or at least is being considered. Although for now in the United States, for equity, until everyone who wants a vaccine has gotten their vaccine, we've put a pause on our ability to give additional doses of vaccine for this vulnerable population. So in order to best protect this population as well as the general population, I would consider the impact of moving forward with vaccination as rapidly as possible so that we could then reach the point where we could provide additional vaccines for this vulnerable immunocompromised population. So I'd just like the committee to think about that and take that into the equation.
Thank you very much. Dr. Talbot.
Thank you. Sorry about that. I lowered my hand instead of hitting unmute. So I have a few things, and I'll try to be very direct. My major concern about talking about risk is that people are confusing the risk of this adverse event to those of oral contraceptives. And it's not the same risk because it's not necessarily the same type of clot, and it's not the same type of treatment. When women present to the emergency department with a clot, all of the protocols and all of the nation and all of the hospitals say start heparin. And that will put these patients at increased risk. And so I don't think they are the same risk. And it shouldn't be compared to OCP. So that's my one thing if you're going to advise about risk, but make sure we make it very clear that this is not a lead clot that we treat with heparin. Two, I think we don't have individual risk factors. What we have is age and sex. And so I think it's really important that when we talk about this, that we do include gender in addition to age. I don't think that we can ignore the fact that the majority of the cases have happened in women. And I also want to reiterate that women often present to emergency rooms with vague symptoms like headache or nausea and vomiting and get sent home and are not taken seriously. So I think that also needs to be remembered when we talk about the risk of this. To Dr. Cotton's comment and some comments about those that are homebound, we have seen in a recent nursing home outbreak that it is incredibly important to vaccinate those around the immunocompromised and those that are homebound.
everyone is worried if we don't have a one-dose vaccine to take into the home, we leave those patients at risk. But I do think we need to really educate the public that they are in contact with someone who is homebound or immunocompromised, that they themselves need to be vaccinated to prevent the risk of spread and an infection. And then lastly, I believe it's the Indian Health Service that has managed to keep, and I could be wrong, I would love to hear them comment. They have managed to keep all 3 vaccines at the same clinics and have done just fine. I think we're Americans. I think we have a lot of ingenuity. I think we can have multiple vaccines at one place. I think we can operationalize this. And I would hate to think that would become an insurmountable obstacle. I think it is more difficult, but I don't think it's insurmountable. And I think we can overcome this, and we can have multiple vaccines, and we can operationalize it. What I worry we can't do is educate the entire medical force and every American about the risk of this with enough detail and enough understanding so that a person can determine the risk benefit for themselves. Thank you.
Thank you. Dr. Daly.
Yeah, thanks so much. So
Dr. Daly, are you speaking?
Yep, sorry, can you hear me now?
Now we can hear you.
All right, sorry about that. So I think it is possible that we're underestimating the benefits of vaccination here, and I just want to highlight that there's at least 2 factors, and there's probably others that may lead to an underestimation. One is the spread of variants that are more easily transmissible and possibly more severe. You know, that would just only increase the likelihood of disease in the unvaccinated. And then a second is that the models that Dr. Oliver presented don't account for longer-term morbidity and mortality from COVID. There was a report out this morning, I think from the VA, that showed that those who had COVID, even who weren't hospitalized, had increased risk of mortality in the 6 months following their COVID infection. So I think we just need to factor that in. And then I also think that if vaccine sites are able to publicize which vaccines they have available, then the public may be able to choose where to vaccinate. I realize that's a challenge because then the public's going to need to be aware of what the recommendations are. But I think that's another potential solution in contrast to having 2 vaccines on site at a given clinic. So with all those considerations, I would favor the 4th recommendation here. Thank you.
Thank you, Dr. Daly. Let me go on to Ms. McNally.
Thank you. I am in favor at this point of option 4. I agree that there are important benefits to the J&J vaccine, and I also think it's very important that people have the right to choose. What I am concerned about is that there is a very rare risk, and we would be warning for those people who may have this outcome. As I look at the EUA of Medical Products and Related Authorities guidance document dated January of 2017, I note that there is a section of this document that talks about information for recipients. And it obviously talks about the importance for people to receive a fact sheet. And I'm trying to balance that against our charter for the ACIP and our description of duties, wherein it indicates that for each vaccine, the committee advises on population groups and or circumstances in which a vaccine or related agent is recommended. And the committee also provides recommendations on the contraindications and precautions for use of the vaccine and related agents, and provides information on recognized adverse events. And I guess I think that this option 4 really accomplishes that, that need for us, and it balances the role of FDA and the role of CDC. And I'm curious about my colleagues' comments on my comments. Thank you.
This is Amanda. While we're waiting for comments, and thank you, Ms. McNally, I do just want to acknowledge that People can sign up for individuals who do sign up online for vaccination. In many places, including at vaccinefinder.org, you can actually put in the vaccine that you're looking for. So we do have tools available online and can ensure that, at least on the government websites where we have those tools, that information about this risk is clearly delineated on those web pages. That does not obviously account for individuals who who do not have that technology or ability to see that, but there is an ability to identify which vaccine a person would like to choose.
Thank you. I see Dr. Long's hand is up and Dr. Sanchez's hand is also up. In an attempt to give everyone a chance to say what they need to say, I'm not ignoring you. I'll just come back to you at the end, but I want to make sure that everybody has a chance to speak here. Before we leave the voting members, are there any voting members that want to make a comment? Just say so. Okay. Let me just add my comments to what has already been said, and I won't repeat a lot of this, but I'll tell you what things that I've thought about. I mean, this is a very rare event, or very rare events, and taken in the context of all the other issues that have been discussed, other factors that are weighing in my decision are the issues of, and as Dr. Daly began to touch upon, these other risk factors that we yet have well to understand, and things such as neuropsychiatric problems associated with their infection, the long hauler syndrome. Those issues are also important, and we don't have data on that. And so limiting the vaccine to a greater population certainly would have impact on that. The issue of individuals returning for a second dose is one that's important to me. In a recent MMWR that looked at doses given between the start of the immunization drive into the middle of January, 3.4% of the population surveyed did not return during the window. I can tell you that data for my state as of yesterday was 11.1%, 3 times that. So clearly removing a vaccine that can be given as a single dose and is a preference among Latinos in our communities would be of detriment. And so I think that these weigh heavily on my decision, and as has been said before, I am leaning towards the number 4, or the option number 4. So let me open it up now to the liaison members, and I see Dr. Dushin is top on the list.
Thank you, Dr. Romero, and to everyone who has contributed to these fantastic analyses and presentations. My question is about the model, and I think it's clear that both on the population health level and the individual health level, the benefits of this vaccine justify the risks. And this is an incredibly important vaccine that we need in our armamentarium, as Dr. Romero just described. My question is the risk-benefit calculation is based on the current U.S. exposure risk. And over time, I believe, with these effective vaccines, the risk will recede. And I'm wondering what type of additional information we can get that will help us better understand where the disease incidence, at what level of disease, at what incidence level, this risk-benefit equation will change significantly to help guide our future use of the product. Thank you.
Rachel, do you want to comment on future use of the models?
Sure. So the models have been used in previous ACIP decision-making and have been updated as additional data become available. That's a process that we're happy to continue as we learn more about what future incidents will be. It's also why we included 2 scenarios, both that low and that moderate scenario that were included in the population level models. And so I think that we're happy to continue reassessing and providing that evidence for ACIP.
Thank you. I think that will be incredibly useful as the risk of COVID-19 recedes.
Thank you. Dr. Gluckman, please.
Thank you very much, and appreciate Dr. Oliver's thorough presentation. I would just refer folks to slide 51 of Dr. Oliver's presentation, where it puts an excellent perspective on the risk of TTS versus the potential benefits. I think that option 4, while it's important to make people aware of the risks of TTS, while that information is being provided, it is essential that people are also provided with the overwhelming benefit. For every case of TTS occurs, there are still 12 deaths prevented, 127 ICU admissions, 657 hospitalizations prevented. And then, as people have already commented on, the potential risk for long-term sequelae of COVID as we're learning more. I'm concerned that without a stronger statement from ACIP, that a decision could contribute to vaccine hesitancy, and that any contribution to vaccine hesitancy is far more likely to cause real harm to people. So while yes, information is important, we should be making a very strong and unequivocal statement about the overwhelming benefits, and recognize that there is some issues around feasibility in certain populations. Of course, when people have the opportunity to have choice, they should have choice. But I think the overwhelming risk-benefit analysis here is get the vaccine you can get.
Thank you. Dr. Shaw.
Thank you, Dr. Romero. I'd like to begin by thanking Dr. Oliver. Dr. Oliver, you gave a clinic today on the optimum way to analyze and communicate about a difficult public health policy question, and I commend you for your clarity of thought and communication. It was outstanding. I'd like to address or think about what has already been noted, which are some strands between the differences between, Dr. Oliver, your option 2 and option 4. Even option 4, well, there are 2 observations I'd like to make. Both options, as your slide 71 notes, provide flexibility of choice as well as allowing receipt of this vaccine among hard to reach populations. I think it's important to note that believe that both options, even though it's only noted explicitly in option 2, both options would entail an official recommendation being appended to the EUA, as our colleagues from Janssen noted. And so with that, I suggest, or I posit that there's not so much of a difference between option 2 and option 4. It may come down to our understanding collectively of the language of may choose. So long as we understand that may choose is at the population level, as some commenters have noted, it may entail choosing when someone is making their appointment or at the time they decide to go get vaccines. I think at the practical level, most sites will not be able to offer 2 vaccines. In our state here in Maine, I'm not aware of a single vaccination site that simultaneously is running 2 vaccines at once. When we adjust for that understanding, I don't know that there is much of a difference between option 2 and option 4. The choice here, which I believe in retaining, comes at the time that someone decides to seek a vaccine rather than at the point of care or point of service. That's my understanding, though, Dr. Oliver, and I'd love your perspective on that.
First of all, thank you. That was very nice. I actually agree, and first of all want to reiterate that your first point that absolutely all of the recommendations are in the context of FDA's warning statement. So we were highlighting it for that second one, that it's not necessarily going back to what we had before, it's with the setting, but yes, that any kind of future recommendation for use will be in the setting of the FDA's warning statement. And agree that in many instances it will be up to the jurisdiction exactly how that kind of may choose another vaccine gets implemented, but very likely in many instances would be an individual person signing up for which vaccine appointment they're going to take, which just reinforces the importance of, the public, clear communication that we've said if this is the choice ACIP will choose, that CDC will work with colleagues at disseminating.
And sorry, apologies for honing in one more time, but that option of choice already exists and is baked into option 2 as well.
Yes, correct. I think it's my interpretation from the work group's discussion, and I'm happy to, after this, kind of defer to Dr. Bell if she wants to comment again. But my interpretation was it's really option 4 is ACIP reinforcing the risk in this specific population, but that, in many situations, the benefit may outweigh that risk. Dr. Bell, do you have anything else that you would like to add for kind of work group summary?
Thanks. I guess I would say to reflect to the extent that I can reflect the work group's sense and my own opinion. I think that the issue is that we think it's important to reflect both truths, both the fact that the benefit risk is, in favor of a large benefit, but also that there is a very small risk of a serious adverse event, which people have should be aware of. So I think the idea is to reflect both truths in the language of the recommendation, to fully acknowledge both the benefit and the risk. And I think that is a little bit different than option 2, which wouldn't reflect, I don't think, in the same kind of way, the ACIP's recognition of both and the opportunity for people to make an informed choice. So that, I think, is perhaps it's a small point when you come right down to it, but I think that's essentially where it was coming from.
Thank you very much.
Dr. Bell, since you have the floor, I see that you also had your hand up to make a comment. Would you like to continue with your comment or question?
Well, I was going to just, sort of provide my own perspective on kind of where I've come down in terms of how to approach the situation here. So I'll just make a couple of points and try not to be too verbose. I think, first, I think it's very important to recognize that this is a recommendation and a policy for now and for the current situation, which includes, which is not at the moment with COVID-19 at bay and things quiet and all those lovely things that we can hope for in the future. So this is a time where we need options and we need flexibility. And that's very much part of my thinking. I think the second point is that the benefits do clearly outweigh the risks from a population perspective and an individual perspective. And I think it's reassuring to me anyway that while we don't have all the information, I think we do have enough information to move forward. But at the same time, I think that there is a real risk. It's admittedly an extremely small risk and smaller than many other risks that we choose to take every day. But nonetheless, there are alternatives, at least, for us in the United States. And for that reason, that's, as I just mentioned, why I personally do prefer wording which explicitly recognizes the ACIP's recognition of both the risks and the benefits. Now, it's a little bit of a paradox that here, there's been a lot of discussion about vaccine hesitancy and what do we do about that. And my own feeling is that that's just an unknown, and we do the best we can. It's a paradox that by recognizing and detecting and acting on a very rare risk, which should in fact inspire vaccine confidence, perhaps it has the opposite effect. But in any case, I think that going forward, and this is something that a couple of people have already raised, I think that the success of this policy recommendation, whatever it is that we end up, but especially if we choose this last option, is, and also to support public confidence, it really rests on education and communication. And it's really critical that CDC, that the state and local health departments, that our partners really step up and take this task at hand and really work to make people understand what the choices are here. Thanks.
Thank you. Let me apologize, Dr. Goldman. I jumped you to go to somebody else. Please, if you have questions or comments.
Thank you. Appreciate it, sir. I'll make my comments brief so as not to reiterate everything that's already been said, but I'm a firm believer that the perfect should never be the enemy of the good. I think the risks and benefits of this vaccine clearly show that we're preventing tremendous disease and that we need to be cognizant of that fact, because to not continue the use of the vaccine would be detrimental for the overall vaccine program and preventing tremendous amounts of death, hospitalization, ICU care. But I did want to point out just a few concerns from the private practice and primary care perspective. Certainly, you would think we would be able to at least stock one vaccine, let alone two, but what is happening on the ground floor is that many of us cannot even get any vaccines to give out to any of our patients. So if we do not even have the option of a single-dose vaccine, it is going to tremendously affect the ability of vaccine distribution for many in private practice and primary care, number one. Number two, many of my patients are expressing a preference for the vaccine for a single dose because they cannot take off from work for 2 visits. They do not have the access to the care. There's certainly that health equity piece that we must be extremely aware of. So I'm greatly concerned that if we do not continue with the vaccine, it is going to dramatically reduce the ability of many patients to get vaccinated. So I also firmly believe in patient choice, and that I do think option 2 keeps it as simple as possible to make sure people can have that choice. They'll know what the FDA recommendations are and be aware of it. And my last point is that we need to be very careful in the wording that we use, because what this pandemic has shown me is how many jurisdictions will misinterpret guidelines out of convenience. And I point to the example of when we said that up to 6 weeks you can give a second dose. Many jurisdictions split the difference and just did 4 weeks across the board for both vaccines, even though that's not what the recommendation said. So I do think we have to be very careful in the words that we use and how we recommend it, as many jurisdictions might misconstrue that out of convenience as opposed to what's best for public safety and public health. Over.
Thank you for those comments. Dr. Freihofer.
Sandra Freihofer, liaison for the American Medical Association, but I'm speaking as a practicing physician. And as Dr. Goldman mentioned, I think it's very difficult for private practices to carry more than one vaccine at one time. I am very concerned about vaccinating homeless, homebound, the incarcerated, vulnerable populations. And we really do depend on this one dose and you're done vaccine with the easy storage to reach those particular populations. I'm very concerned about the variants and was impressed with the presentation by the company about coverage of this B1351 variant. I'm also concerned that a lot of these vulnerable patients and vulnerable populations would not be able to get a second dose of vaccine and might not return for that. So feel very strongly that we need to have this vaccine available. I also feel very strongly that patients should have a choice. And I was very encouraged by Dr. Cohn's statement that there is a way on the vaccine, looking for a vaccine, that you can determine a place where you can get the particular vaccine that you want, because some people really care about which vaccine they're getting. Some people may not be as interested. But I was wondering about, and I liked what Dr. Bell said about the two truths. Wanting to, and the reasoning behind her choice of option 4. But I share Dr. Shaw and Dr. Goldman's concern that it's just a little complicated and the wording makes it sound a little shady and might be discouraging, and I worry about increasing vaccine hesitancy. And I asked Dr. Cohn, if you had the recommendation, reaffirmed recommendations for all sex, age, and sex, and if you had that FDA warning in the EUA, how would that change the outreach of the CDC to make sure that practitioners, that clinicians, that the public understood the risk and the side effects? Because it's just a much simpler way of expressing the same thing. And I didn't see really much difference when I thought about them.
Dr. Freihofer, we would, CDC would develop, if for either options 2 or 4, CDC would develop the same tools and communication and education products to help women and providers understand the benefits as has been recommended, as well as the risks.
Thank you.
Thank you.
And thank all of you for a great presentation today. It's just, I'm so proud of the hard work and all the detail and research that's gone into making sure that our vaccine safety surveillance system is looking after the American public.
Thank you. Dr. Zahn.
Thank you, Dr. Romero. And I'd like to echo others' comments and appreciation of all of the outstanding presentation and conversation today. And Dr. Freihofer actually touched on it, but I guess I was following up on Dr. Shah's comments about the difference between option 2 versus option 4. In public health, we're anticipating that we're all anticipating over time the mass vaccination events and the pods we set up where hundreds of people show up, those are going to go away. And at that point, for public health, from our side, we, with a lot of community provider assistance, really anticipate reaching out to communities, reaching to them where they are. Obviously, the homeless population is an obvious group that will need this outreach. But when we're reaching out, option 2 versus option 4 would be really quite different. If there are potential groups who would not be indicated or would not want to have the vaccine, then you potentially have to bring 2 along. That would be logistically difficult. And I think more than that, a lot of outreach partners that we're relying on that have done such great work have been first responders, volunteer nurses, people who do a great job vaccinating, but I'm not sure are going to be tremendously comfortable talking through the risks and potential pluses and minuses for women about the issue when they may be the first person to talk to them or the first medical provider to talk to them to broach the issue that they need to be vaccinated. So certainly understand the issue. This is not simple, but if you add the wrinkle of women under 50 be aware and they may choose, then the logistics of those outreach, can we do it? Yeah, absolutely. Does it become more complicated? Yeah, it definitely does. So.
Thank you. I see Dr. Lee has her hand up, and I don't believe she said anything in this session yet. So, Dr. Lee.
Thank you so much. I'm going to start with a slightly long preamble, but I promise I'm going to get to my point, which is number one, clearly at a population level, the benefit-risk balance favors vaccine use. Even in the last 11-day pause, what's striking to me is that there have been deaths and ICU admissions that would have been potentially preventable had we not done the pause. At the same time, though, I recognize that the last 11 days to me have been reassuring in that we haven't identified, hundreds more cases despite enhanced awareness and case finding across the U.S., which was actually my worry last week. We have a lot better information about the risk estimates by age and sex, and I think that can inform our decision making today. So just in sum, last week I would have made a different decision than what I would advocate for this week. From an access and acceptability standpoint, I just want to state that, ACIP's role, I think, in this instance should be to ensure access to vaccine. Individuals should absolutely be well informed, as they always should be, and they should have the ability to make an informed choice and encouraged to talk with their healthcare providers if they wish. But that acceptability is not just a J&J issue, it is a much broader issue. So I think that we cannot do enough to support and ensure that we are always educating patients and the public, and we need it on all fronts. So I don't actually think this it is a very specific issue, but I feel like it is a much broader issue that we need to address. On the implementation front, I just want to state that, we are going to have these issues all throughout. Right now, we have one vaccine available only for 16 to 17-year-olds. So in order to be able to ensure access, we are functionally carrying multiple products, maybe not on the same day, but many sites are doing this in order to ensure access to 16 and 17-year-olds because we only have one product available currently in the US that goes down to that age group. And we do have vulnerable children in that age group. Finally, from a communication standpoint, I want to emphasize the point that was made earlier that this is not just risk communication, it is benefit risk communication. And that similar to what we've done for anaphylaxis and making sure that people have the tools and the communication and the sort of screening available at vaccination sites, I kind of think that same approach needs to happen here, and would also just make sure that everything that we're doing incorporates health literacy principles and multiple languages to ensure that we are truly informing everyone who may wish to have the vaccine. But I'm going to actually now take a different stance, and I did not at all in the beginning of today think I was going to take this stance. But from a process perspective, I actually think we need to think really carefully about the implications of what the recommendations will be. So for me, I'll just state at the outset that number 1 and number 3 are off my list. I've been thinking carefully and listening to the arguments for 2 and 4 here up on the slide, and having spent a lot of time with that evidence to recommendations framework, I do not think that 4th recommendation falls within what we would normally consider as a recommendation per our usual framework. It really should fall under 2, reaffirm recommendations for all age and sex, with the same comment about the FDA warning and all of the information that I think is in 4 absolutely needs to happen. I was feeling at the beginning of today that I needed all that additional information in 4 to feel comfortable with any recommendation as a way to state sort of our concern about the benefit risk balance. But I have to say that I think it's going to be actually extremely confusing because every recommendation we make is a benefit risk balance, and we cannot parse out every single benefit and risk in every single recommendation for every single vaccine, COVID or non-COVID. So I actually think we need to, from a procedural standpoint, go back to number 2 and make sure that all of the discussion points that were brought up for number 4 are incorporated in the way we implement, but that the recommendation should be consistent with the evidence to recommendations framework. And I would love to hear comments about that.
Thank you very much. So to everybody who still has their hand up, and to those that want to make a comment, we will try to get to everyone. I want to remind you that we're scheduled to end at 5 p.m. Eastern time. We could go over, but really want to stay to that window. So we'll go on to the comments. Let me see here. Dr. Grog.
Yes, I'll keep it simple, representing the American Osteopathic Association, but I have an immune deficiency and did not respond to the vaccine. I think that we have caused a lot of vaccine hesitancy in our pause for the Johnson & Johnson, and as others have stated, it's been some deaths in ICU and hospitalizations and long-term sequelae and things that have probably happened over the last week. I would like to see, I'm confused whether it should be 2 or 4, but I'd like to see everybody vote forward on the J&J vaccine and heavily inform our healthcare providers about insulin and other things, and let's get this done. Thank you.
Thank you. Dr. Hayes.
Carol Hayes with the American College of Nurse Midwives. I've been working in a mass vaccination clinic, and I want to reassure you that we have carried all 3 vaccines, and we have little tents set up and where our little cubicles are numbered, and somebody in the back room draws up all the vaccines, and I just sit there and jab the arms. And it really is possible to stock 3 vaccines and to organize at 3 vaccines and to have people choose when they walk in the door which one they want. And I also want to just thank everyone who's presented all the data today. Everyone did such a fabulous job. And I also want to reiterate what Dr. Lee just said, that I feel as though at the beginning I was going to be a number 4 girl, and now I'm a number 2 girl. So thank you.
This is Amanda. I'd like to I'm going to ask Dr. Oliver to put some additional language, listening to this discussion about 2 and 4 for people to consider. We have a lot of people whose hands are raised, so this will just give you one more thing to comment on, as Dr. Romero said very briefly. But I'm going to hand it over to Dr. Oliver. Are you ready? I don't think, yeah, just say it and then, yeah.
So we'll work on getting these to where we can project them in just a second. But the language that was voted on previously says the Janssen, which would be option 2, the Janssen COVID-19 vaccine is recommended for persons 18 years of age and older in the U.S. population under the FDA's emergency use authorization.
And then the proposal would be for that, with that language in the recommendation, we would then describe the risks and benefits and in the clinical considerations section, but have the overall recommendation point to the EUA only. So it's essentially 2 with the additional language pointing to the FDA emergency use authorization.
Yeah, go ahead.
Yeah, and Sarah's going to repeat the current language for number 4.
So for an option number 4, the vote would say the Janssen COVID-19 vaccine is recommended for persons 18 years of age and older in the U.S. population under the FDA's emergency use authorization. Women aged less than 50 years should be aware of the increased risk of thrombosis with thrombocytopenia syndrome and may choose another COVID-19 vaccine authorized for use in the United States.
And I think since we haven't heard anybody supporting 1 or 3, we're going to send these 2 language options in a slide, and we're going to project those up for people to review.
So we're going to take some comments while they finish the slides. Dr. Eckert, please. Dr. Eckert? We'll come back. Dr. Alt?
I don't see a huge difference between 2 and 4, if depending on the way the warning statement is in the EUA. It looks like it would have to duplicate a lot of the information we already have in 4. Does the language for the warning statement exist somewhere? Is there some way to look at it, or does it need to be developed still?
This is Dr. Oliver. It was presented at the very end of the Janssen slide. When we get through our slide stuff, we can we can show that again.
Thank you.
This is Dr. Eckert. I'm sorry that there was a leaf blower right outside my door right as you called on me, and I thought, oh my goodness, you will only hear the leaf blower. So
Please go ahead.
But I just want to say, as an individual here, not speaking on behalf of ACOG, this is my individual thoughts, but my concern is that number 4 does potentially enhance obstacles to vaccination. And we have definitely seen that individuals who are pregnant have met frequently with obstacles. And I question whether, since the CDC will and has been doing a great job with information and information sharing, if doing that for number 2 and number 4, like Dr. Alt just mentioned, if they're really all that different. And so I personally would advocate for having the fewest obstacles as possible in the way of vaccination and going with number 2. Thank you.
Thank you. Dr. Weiser.
Hi. I just want to comment on the fact that Indian Health Service arguably serves some of the most remote and hard to reach populations in the country. And in our jurisdiction, we've been receiving all 3 vaccines and providing all 3 vaccines. And some of our sites are actually handling all 3 vaccines. The Pfizer just for the 16 and 17-year-olds, the Moderna for the majority of the adult population, and then the Janssen vaccine, which some people were waiting to receive and not choosing to get the other one. So as part of a health system, I think we have proven that we can handle all 3 vaccines. Typically, when we have a large vaccination campaign or site, we'll give mainly 1 vaccine on that day if we're doing a drive up or a large scale vaccination event. But we have the ability to keep the vaccine straight and make sure that people get the vaccine that they've asked for. Thank you.
Thank you. Ms. McNally?
Thank you. I just want to confirm that the FDA agreed warning and precaution regarding thrombosis with thrombocytopenia that the Johnson & Johnson presentation showed is what would appear in the EUA fact sheet for recipients.
Would somebody from the company please respond on that question?
Yes, this is Dr. Waldstreicher. That was the fact sheet for healthcare professionals, and the one for recipients is different, but it's very clear, and it gives information for recipients about the signs and symptoms and to present if they have any of the following of those signs and symptoms, as well as describing the overall event as well.
I find this to be very relevant to the discussion, and wondering if it would be possible to see some of this proposed language. And I mention it because of the fact that informed consent is not required for a product authorized under EUA.
Excuse me, this is Dr. Bell. Would it be possible for FDA to make a comment about what is going to be in the fact sheet?
Yeah, hi, this is Doran Fink. I think it would be best if Janssen has the ability to share the language for the recipient fact sheet for them to do that.
Dr. Marie, you have that in front of you. Would you be able to do that?
We can also continue on with comments and give you guys a few minutes. If you'd like to send something, we can project it.
Yeah, I think that would be good, so we can move through these.
Thank you.
Let me go back to the top of the list and work my way down again. Dr. Long, please.
I agree with so many things that people have said, especially Dr. Bell and Dr. Lee. I think we shouldn't talk about this as very rare or, you know, you can't, I take it all out of all medical writing. Rare is rare, and it's difficult to quantify. If we're talking about the age group of women that we're talking about, it's 1 in 140,000. Now, some people would say that was rare, and some people would say, I would never say it was very rare. The other thing is that people perceive and want to take risks at different levels. So I think we want to be sure that we do allow choice. The next comment is, because it's difficult to do doesn't mean that we can abrogate our responsibility to protect the public as well as individuals. I think if we had 3 vaccines, they were all single dose, they had the same efficacy, we would be preferring another vaccine, and they were all available. We would be preferring 2 other vaccines in this age group. I certainly would be preferring that. And I don't say that we should say that specifically now. I think we want to reaffirm that the vaccines themselves, the benefits outweigh the risks. or the next thing is that you ought to receive any vaccine you can get as soon as you can get it. And then we have to have a different way to say number 4, because number 4 to me kind of comes out as a petulant young woman rather than we're experts. We recognize this risk. This risk may be more important to some people, or maybe a single injection is more important to that young lady who's choosing between vaccines. But to say may choose, I don't think it's saying what we recommend. And I'm not for just leaving the FDA warning, because the FDA does the licensure and the legality part of it. We're supposed to nuance that by all of our deliberations to protect the population as well as to protect the individual. And I think that the benefit outweighing the risks in that younger age population of women, I don't think that I buy that, that they won't otherwise be vaccinated. So I think we have to do justice to both truths. And so I think the way you're using the words now are good. I just think we need to have something better than may choose.
Thank you. Dr. Sanchez.
No, thank you. I agree with Dr. Long. I actually had a question and then a comment. When you look at the list of women, and remember one was a man who had the thromboses. One of them was 59, and I know that the risk benefits and the risks were all greater than 50, but any consideration of age 60?
This is Sarah. I think the work group, we tried to look at what was known with the current age distribution. We had to make some assumptions when we started doing this work a couple of days ago. And so the work was done with the 50-year-old cutoff. I think we did look at information. So the work group saw more slides and more information than what was presented publicly today. There was some information presented for 65 and older, so not 60, but 65. Ultimately, the issue is the population 65 and older that's remaining to be vaccinated is very small, or is much smaller than the 50 to 64-year-old population. And so some of that definitely impacts the modeling results when it comes to that. But we did not specifically look at a risk-benefit analysis with the line drawn at age 60 years.
Because when the data as of April 14th, among the cases, the range was 18 to 59. And I know that it's just some cases, but because I fully understand the benefits of immunization. We cannot argue with that. But I also understand the risk, and the risk is not it's not an insignificant risk. It makes me nervous. And I think that that at least with this vaccine, yes, there's only one male during the trial that had it, so it doesn't seem to be zero in men, although yes, quite rare, or quite infrequent. And I just, I think that the choice, as one of them, as the number 4 is worded, it sounds almost like the choice should only be given to women and not to everyone. And so I'm a little bit hesitant about that one as well. But I'm not sure if 50 is the age cutoff that I would use.
Thank you. Dr. Paling. Dr. Paling? We'll come back to Dr. Oh,
thank you.
go ahead.
I'm here. Thank you.
Ms. McNally shared her thought process of how she was thinking about this and put it into context and asked for a response. I wanted to respond and affirm that I am thinking along the same lines and appreciate her adding clarity to this thought process. I also wanted to say thank you for getting the exact wording for the public, because that is a very important part of the consideration for me. Thank you.
Thank you. Ms. Hayes.
I apologize. I forgot to take my hand down.
Thank you. Dr. Holly? Dr. Howell?
Oh, hi. Thanks. Molly Howell, representing the Association of Immunization Managers. I just wanted to say that yesterday we surveyed our members, who are the 64 awardees implementing the COVID vaccination programs in the United States, and 81% were supportive of, I would say, either option 2 or option 4. So I just wanted to share with that, and that we will work with either. Thank you.
Thank you very much. Dr. Stinchfield.
Yes, thank you, Patsy Stinchfield, representing NAPNAP. Personal thoughts here from the state of Minnesota that is seeing all the variants and increasing numbers, and as we speak are accepting young adults into our children's hospitals because of very high census across the state with the disease. So what makes me nervous is the climbing incidence of COVID. I have an urgency to move on this, what our former option 2, which I think we'll now call the top box. I would support that. And I think because it's most reflective of the data that we've seen today and the conversation, I think it is will have the least unintended consequences for those who are reading it. And I do think in a hospital that's given 20,000 doses so far, 2 products, it is very doable to have 2 different products. For example, our Johnson & Johnson, we've been very happy to give to 18 and over young autistic males who are combative. They're under a sedated procedure, and it's worked out really, really well. An already planned procedure. We co-administer that vaccine with very happy families at the end. I think, we can do these on different days, different sites, different locations. So that implementation, I don't have any concerns about that. I do think that in terms of vaccine hesitancy, yes, I think this pause has made people nervous, but I think in the end, time will tell. But because of the excellent work, and Dr. Oliver, what a masterclass you gave us today, this will help increase the confidence in the United States and across the world. And I'll just end by saying that I do have a considerable concern about our global problems right now, looking at India and Brazil, and the urgency, again, not only in the US, but across the world, to use all the tools that we have to get the pandemic behind us. So I feel very comfortable in that top phraseology with the details in the EUA. Thanks.
Thank you. Dr. Whitley Williams.
Yes, thank you. Pat Whitley Williams, representing the National Medical Association. And I also thank you, Dr. Oliver, and your group for just outstanding presentations. Our preliminary considerations would be supportive of reaffirming the recommendation for use of this vaccine. It's well recognized that persons in the Black and Brown community have been disproportionately affected by this pandemic. So the benefit of a vaccine that is effective far outweighs the risk, and especially in hard to reach vulnerable populations. And I also concur with what Patsy Stinchfield just said in terms of the global impact. But also would encourage, and I know this is work that's ongoing, to really try and get to the bottom of this underlying cause of the TTS, and particularly as it relates to age group, gender, and race ethnicity. Thank you.
Thank you. Dr. Arthur.
Thank you. Phyllis Arthur on behalf of BIO.
I actually just wanted to suggest that whatever the decision the ACIP voting members make, this is an excellent opportunity to recommit to getting all the vaccinees to use BSafe. We think this is an extremely important tool for helping people pay attention to their side effects, report them, and gather the really important data on vaccine safety that's so important to our overall efforts. We've had many reports of people not being told about BSafe when they get vaccinated, although other places are doing a great job. And this is an opportunity, given any need to change the daily information people get in the text, to actually encourage more and more citizens to enroll and fill it out. So just wanted to put a word in for, as we look at BSafe, having another wave of encouraging people to use it.
Thank you. Dr. Bernstein, I'm going to skip you because you've already spoken. I don't think we've heard from Dr. Chen. Dr. Chen, and then I'll come back to Dr. Bernstein.
Yes, thank you. And so I've been really enjoying the discussion, and I think I agree with what Dr. Shah initially kind of articulated, which is that in essence, box top and box bottom are not significantly different from each other, as long as we understand that in the implementation that we would not, have a formal, complicated consent process for the be aware or making aware statement, and then for the ability to choose, that we would not make it a requirement for the local point of immunization clinic to be required to store 2 or more vaccines. So I think that as long as I understood that correctly, there really isn't that large distinction between the top and the bottom box. And so I do wonder if that bottom box, having not much of a real distinction, has more of a risk for misinterpretation from local kind of smaller implementation teams and programs. I think we heard from other large programs that they have no problem with juggling, 2 or 3 vaccines simultaneously on any single day. But I do wonder about these smaller outfits. Again, in my state of Maryland, we have, individual medical practitioners and pharmacists, dentists, and veterinarians that are starting to be trained to be able to implement these vaccines. And again, I can't imagine that they will be able to juggle multiple products simultaneously. So I think that, again, as long as we saw that enhanced labeling information, and we have an aggressive campaign for educating the public and the medical community, I think in essence, those boxes are not really different from each other. And to make it simpler, that top box is really what I favor. So I'll stop there.
Thank you. Dr. Lett?
Yes, hi, this is Lett from CSTE. We're wondering if you could tell us a little more about implementation, will happen, because this is we've never sort of had this pause before, and sort of sequentially, can you describe it?
Dr. Lett, you're asking us to describe the pause? Oh, the implementation of if the pause is lifted?
Yep. Yes, there have been some questions amongst our members and other members that we've been talking about how exactly things would get re-implemented as soon as we have to wait for certain language to be available, for materials to be available, I don't know about screening forms and standing orders. We're just trying to understand how that would happen.
Dr. Lett, this is Amanda. So if there is a decision in the next half hour, hint, hint, sorry, then we are awaiting and anticipate that the FDA will be putting out newly approved EUA language, which we've pulled up for you to see now, the language which we can have the company take us through, that's in the patient FAQ sheet. And at that time, if the CDC director approves the decision made by CDC, we would publish that on the ACIP website and through other information sharing, and people would be allowed to presume use of doses that they have available potentially already. That being said, immediately over the next 72 to 96 hours, so Monday there's going to be another COCA call that describes all of this information. There will be an MMWR that shares all of this information. And additionally, we will be taking the input from today along with this language that FDA will publish, and both FDA and CDC will have communication materials and education materials, including infographics, patient fact sheets that are smaller and focused just on this issue, and those will be available early next week.
Do you want to walk through this, and then I'll take the final questions that are here. So go ahead.
Yeah,
Go ahead, J&J.
This is Dr. Oliver. Yeah. We just got the recipient fact sheet. So if somebody from J&J wants to walk us through that.
Yeah, certainly. This is Dr. Waldstreicher. So this is the recipient fact sheet, and this is the section that's on the risks of the Janssen COVID vaccine. Prior to this, it first describes the side effects reported, like injection site reactions and general side effects. Then it talks about anaphylaxis and gives the symptoms of those. And then you're seeing the section there highlighted in yellow, where it talks about this new thrombosis with thrombocytopenia, but in language, appropriate language for this fact sheet. So it talks about blood clots involving blood vessels in the brain, et cetera, goes through those. It talks about it's occurred in some people who have received the vaccine, and in people who have developed these clots. I'm not going to read the whole thing word for word, but it talks about the fact that they develop approximately 1 to 2 weeks following vaccination, and that most people who develop these blood clots and low level of platelets were females ages 18 through 49 years. The chances of having this occur is remote, and you should seek medical attention right away if you have any of the following symptoms, and then it gives the list of symptoms. This is consistent with professional society guidance as well. And that's the end of that section.
Thank you.
Dr. Romero, may I ask a follow-up question?
Go ahead, please.
Does this fact sheet indicate that there is an alternative, that being the mRNA vaccines?
What the fact sheet shows, and it's actually later on down there, it says other vaccines to prevent COVID-19 may be available under emergency use authorization. It's probably there if you scroll down under Janssen. The question is, are other choices available for preventing COVID-19 vaccine? It's up a little bit. I'm sorry. Are other choices? Oh. There it is. Okay. Are other choices available for preventing COVID-19 besides Janssen COVID vaccine? Currently, there is no FDA-approved alternative vaccine available for prevention of COVID-19. Other vaccines to prevent COVID-19 may be available under emergency use authorization.
And this is Amanda. I'll just add that in the CDC educational materials, we will describe all options available, and we're able to speak about all of the products as opposed to the EUAs, which have to focus on the individual product that it's authorized for.
Thank you. The information is very helpful.
Dr. Romero, this is Dr. Bell. Can I just ask one follow-up question before we head on to the other people with questions?
Of course, Dr. Bell.
Thank you. So this EUA fact sheet is given to patients when they're getting ready to have a shot. Is that correct? In other words, they're in the clinic, they're about to get a shot, and it's the Janssen vaccine, and so they get this piece of paper. Is that how these EUA fact sheets are used?
Does someone from the company or FDA want to respond to that?
Yes, generally, this is how the fact sheet is used. That we also post it on the website, and I believe that it's posted on other websites as well, such as that would accompany the vaccine.
I will tell you in practice that there are, that sometimes you receive this information through your appointment. You receive an email with the PDFs of this information as well, but it should be given at some point between when you make an appointment and you get vaccinated.
Thanks.
Sorry, I lost my list of speakers here. Let me go back to Dr. Bernstein, then Dr. Paling, and then I'm going to close it unless somebody has some very pressing comments. Dr. Bernstein.
Thanks, Dr. Romero. It's incredibly impressive to me how well our nation's vaccine safety surveillance systems work. The Vaccine Adverse Events Reporting System, VAERS, which is not designed to assess causality, identified a safety signal of real concern, prompting further investigation. As Drs. Oliver, Bell, and the COVID-19 work group have presented, the ACIP closely examines disease epidemiology, vaccine supply, implementation concerns, public values and acceptance, and equity. Its three overarching pillars of science, implementation, and equity are important. After our emergency meeting last week, I felt implementation and equity favored reinstituting the J&J vaccine, but the science was much less clear to me. The brief pause, measured in days, appropriately continued to allow additional data to be collected and analyzed. The ACIP process works in a timely and transparent way, which should improve the public's understanding of this safety signal. Today's presentations and discussions have convinced me that lifting the pause on J&J's vaccine is in the best public health interest of the U.S. population. Any vaccine may have side effects, and in this case, the risk of blood clots and low platelets, even resulting in fatality in some, has now been extensively studied and will continue to be monitored. Plus, patient education and provider recognition are expected to help improve outcomes. Important information also will now be conveyed in the FDA's EUA fact sheet, the CDC's materials, and through local public health officials. The three COVID-19 vaccines currently authorized in the U.S. are amazingly safe and effective. In my mind, their benefits far outweigh identified or perceived risks. We need as many people to be vaccinated as possible in order to reach community immunity and put the pandemic behind us. The J&J vaccine will help us do just that. So I prefer the option 2 or the top box, and I think that we can include nuanced language in our clinical considerations that often accompany these recommendations. Thank you.
Dr. Paling.
Can we pull up the FDA EUA sheet again, the bolded part? I wanted to look at that. And in particular, my question on that for the component to the, I was looking at the one for patients in the public. And in that yellow component, my question, I just wanted to highlight that headaches are the most common early symptom of these thrombosis and thrombocytopenia. And so I am concerned that that is buried. I think it was the 5th one down. And I hope on the CDC website we could elevate that location. And I'm happy, I would appreciate input from the FDA and the thought process of ordering. Thank you.
Go ahead.
This is Amanda. We will take that into account as we're developing our CDC materials. That's a great point. I also want to comment on something that Dr. Talbot said much earlier regarding emergency room and understanding the risk of clots, especially in this age group of women. And one of the key things that we have been communicating and we will continue to communicate in our provider education is that one of the first things that a provider should do is check a platelet count, and that should inform treatment and management. And so we are very grateful to our colleagues at ASH and other colleagues who have supported information around the clinical management to ensure that patients are treated, that this is recognized and treated appropriately early.
So before we move on to a motion, I think we're ready to discuss this. I just want to say the following. While I can vote for number 2, I think we've already begun to see in the discussion that there is a bit of selective interpretation of that recommendation. Women are not going to be offered at that site across the country an option to a second vaccine. And that's going to place certain women at a disadvantage that may decide that the vaccine being offered at that site is not the one for them. And they're going to have to shop for a vaccine. So that is an issue. I just want to point that out. But as I said, I think I can live with number 1 because it does reinstate the Janssen vaccine, which I think is essential to our vaccine efforts. So I think at this point we'll end discussion and see if anybody wishes to make a motion. Voting members, sorry. Dr. Lee.
So I move that we recommend the Janssen COVID-19 vaccine is recommended for persons 18 years of age and older in the U.S. population under the FDA's emergency use authorization period.
The top box to clarify, Dr. Lee.
The top box, yes. Thank you.
Thank you.
May I have a second, please? Dr. Alt?
This is Kevin Alt. I'll second it.
Thank you very much. Is there any further discussion from the voting members only? Let me see here. Dr. Sanchez.
Is it possible to vote between the two?
Say that again. Say that again.
Is it possible to vote one versus the other?
Dr. Sanchez, so for procedurally, the motion that has been made now needs to be voted on, yes or no in and of itself. If this motion passes, this motion carries. If this motion does not pass, we can put another motion on the table.
Is that clear, Dr. Sanchez? We have to vote on this motion at this time.
Okay.
Thank you. Dr. Long.
I will not comment further on this motion.
Thank you. Dr. Bernstein. Dr. Bernstein, your hand is up.
I meant to take it down.
Thank you. So I'm going to ask that all the voting members please turn their videos on and get ready to offer a vote. All right.
So I just want to remind our members, we are still not doing really electronic voting, but as you go through your votes, please let everyone know again if you have any conflicts of interest. And I believe there are a couple of members who will be abstaining from the vote due to being involved in clinical trials with COVID vaccines. So please indicate that. Additionally, at the end, after the vote, we will have an opportunity for those of you who would like to share and explain your yes or no vote. So we will have the opportunity to do that after we go through the members. So Dr. Romero?
Thank you. So the motion to be voted upon is the Janssen COVID-19 vaccine is recommended for persons 18 years of age and older in the U.S. population under the FDA's emergency use authorization. So I'll begin. Dr. Alt.
Alt, yes, no conflicts.
Dr. Bata. Oh, sorry, Ms. Bata.
Bata, yes, no conflict.
Dr. Bell.
Excuse me, yes, no conflict.
Dr. Bernstein.
Frank Bernstein, yes, no conflicts.
Dr. Chen.
Chen, yes, no conflicts.
Dr. Daly.
Daly, yes, no conflicts.
Dr. Fry.
Fry, abstain due to conflicts with clinical trials.
Thank you. Dr. Cotton.
Cotton, yes, no conflict.
Dr. Lee.
Lee, yes, no conflicts.
Dr. Long.
No, no conflicts.
Ms. McNally.
No, no conflict.
Dr. Paling.
Paling, yes, no conflict.
Dr. Sanchez.
Sanchez, no, no conflict.
Dr. Talbot.
Talbot, no, and no conflict.
Romero, yes, no conflicts. Thank you, Dr. Cohn. So the vote is 10 in favor, 4 opposed, and 1 abstention. The motion carries. The Janssen COVID vaccine is recommended for persons 18 years of age and older in the U.S. population under the FDA's emergency use authorization. Thank you all very much. So are there any of the voting members that wish to offer comment at this time?
Please raise your hand.
Yeah. Is Dr. Bell, Dr. Bell? You can stop sharing now if you wish.
Thank you. I wanted to reiterate a theme, which is the importance of CDC and the state and local health departments and the partner organizations providing clear communication and education on this topic. I voted yes. I can live with this recommendation, but I think that under an emergency use authorization, where there is no signed informed consent, that it could be that ACIP recommendations might need to reflect some more nuanced concerns than under the usual procedure. Nonetheless, as I say, I voted yes, but I am concerned that that the consumers and women in this age group in particular will not be adequately informed just by the FDA EUA fact sheets. And so we really are depending on the public health agencies and the partner organizations to make sure that people actually are informed and are empowered and that they actually get a balanced perspective.
Thank you, Dr. Bell. Dr. Alt.
I was going to agree with Dr. Bell. I was thinking the very same thing.
Thank you. Dr. Sanchez.
I agree with Dr. Bell, and actually that is precisely the reason that I voted no. I have no problem with the continued availability of this vaccine. I think if someone makes an informed consent after having and knowing the risks involved, I'm fine, let them get it. But I think that we just making a blanket recommendation, knowing the risks that seem to have biologic plausibility and severity, I think we have to have a stronger language and make sure that people are informed appropriately.
Thank you, Dr. Palin.
Thank you. The detection of thrombosis and thrombocytopenia after 6 cases and over 7 million doses administered clearly demonstrates these safety systems are both sensitive and effective. The COVID-19 pandemic continues to cause significant morbidity and mortality. Not only does COVID-19 disease cause many complications, including but not limited to increased risk of serious clot, multi-inflammatory syndrome, post-infection neuropsychological syndromes, and long hauler syndrome. This pause has been effective in increasing awareness of the rare and serious events of thrombosis and thrombocytopenia, highlighting the importance of timely diagnosis, evaluation, and treatment, and gathering data needed for a risk-benefit analysis. At the population individual level, the benefits of reaffirming the Janssen vaccine is high and outweigh the risk. For all these reasons, I believe it is in the best interest of the public to reaffirm recommendation for this vaccine with the warning added to the FDA EUA. Thank you.
Thank you, Dr. Long.
Yes, I did not object to the recommendation. I objected to the absence of any kind of guidance from us. This is an age group that is most at risk, that is getting this vaccine predominantly to save other people's lives and morbidity, not their own. And I think we have a responsibility to be certain that they know this. And if they choose to be vaccinated with this anyhow, we want to respect that choice. But I'm very sorry that we haven't chosen to put up front the knowledge that we have that this is unique, it's clustered, it's almost certainly related to the vaccine, and there are options.
Thank you, Dr. Long. Dr. Bernstein.
I was wondering if you could clarify when language within the clinical considerations, I think some of the concerns that I'm hearing, I would assume would be written into the clinical considerations that are updated the way they were when we were talking about anaphylaxis initially again with the Pfizer vaccine, and there were clear considerations that were readily available to the public, published on the CDC website and in MMWR, and I would assume that that kind of content would be and language would appear in the clinical consideration.
Dr. Cohn.
Thanks, Dr. Bernstein. So this, all of this language around the risks and benefits and the decision to get vaccinated that were presented in the course of the discussion today, there's language that will still be included in the MMWR. And additionally, the clinical considerations will be updated. We anticipate that if the director agrees to reaffirm this recommendation, that all of this will be published during the day on Tuesday.
Dr. Lee.
Thank you. Thank you. I want to emphasize that I actually agree with all of my colleagues who voted no, that I absolutely think this is a serious adverse event. We need to continue to ensure that awareness is raised. I am perhaps a procedural nerd in that I think that the only choices that we really had were to recommend or to not recommend or to do shared clinical decision making. And I think that the emphasis and the vote itself reflects the challenge that is before us today, or that was before us today, that we need to be able to reflect the importance of this particular adverse event and elevate it. But I also think that we have to come out with a clear recommendation. I think that the recommendation number 4 would have been confusing, and it's actually inconsistent with all of the other prior ACIP recommendations we've given. So I think that is why I had chosen the top box instead of the bottom box. Thank you.
Thank you. I will exercise Chair's prerogative and have the last word. As I stated before, I was able to vote for number one, excuse me. I think that it states clearly that Janssen vaccine can be reinstituted and should be reinstituted. I acknowledge, as does everyone else, that these events are rare, but they are serious. At the same time, it places upon us, those that will make this vaccine available and will be distributing it, to make an informed public about the risks of the vaccine. This is not something that we will be able to simply say we're following the ACIP recommendation. It is our responsibility as clinicians to make sure that women understand this risk, and when possible, that they have an alternative at the same site that you're administering the vaccine. So I will end there. Let me again, I think the Oscar for best presentation goes to Dr. Oliver. There's applause in the room here if you can't hear it. Thank you all for your time. Thank you all, that is the voting members, the liaisons, the ex officios. I don't think I'm exaggerating when I'm saying that I think there's no group that has put in as much time as you have. I thank everybody else in the room. Oh, I'm sorry, forgive me, Dr. Wharton, you're behind me, I didn't see you.
I just wanted to add my thanks to those of Dr. Romero. I know this has been difficult.
We can't quite hear her.
I know this has been difficult and it has taken a lot of time, and we greatly appreciate your thoughtful deliberation.
Is that clear enough for you? Can you all hear that? Why don't you come down here, Dr. Wharton? I think this is important that they hear this.
I just wanted to say thank you to all of you for the time you've put into this, thoughtful consideration, the deliberative process you've engaged in, and your coming to a conclusion on this important matter for us. We really appreciate your support and help, and thank you for everything you've done to support the COVID vaccine program.
Thank you. And again, thank you, Jessica, Dr. Cohn, Stephanie, for everything you're doing. And I'll turn it back over to Dr. Cohn.
Before we close the meeting out, I think just to reiterate, Dr. Wharton, there have been probably hundreds of people working in our immunization safety office and at FDA collaboratively on all of this work over the past 2 weeks. So thank you. I just want to remind everybody that we do have an ACIP meeting scheduled for May 5th to discuss dengue and rabies vaccines. Dr. Oliver is off the hook for that one. But we do anticipate if there is a future authorization by FDA, we do anticipate having an additional ACIP emergency meeting to review any additional authorizations for additional age groups for vaccines in the near future. So stay on the lookout for updates. Thanks.
So with that, then, I will knuckle us out of the meeting. Meeting adjourned.